everybody hear me okay? Everybody in the back? Can you guys all hear me? Well, I wanted to welcome you all to the Parkinson Symposium. It's really, really great to see everybody here in person, but obviously we also have a virtual component, so I want to welcome them as well. My name is Christopher Tollison. For those who don't know me, I am a movement disorder specialist at the Cole Center and also the medical director for the Cole Center. Again, for those who don't know, the Cole Center is our Parkinson's and movement disorder specialty clinic at the University of Tennessee Medical Center. We've had quite a bit going on at the Cole Center in the last couple years. We've moved to a new building, we've added faculty, we started a deep brain stimulation program, we've increased our outreach, we've rebranded, just a lot of stuff going on with us. And in lieu of that, we actually were designated as a comprehensive care center by the Parkinson's Foundation, which means we're going to have more to offer for you guys and we're going to have more funding. We actually joined what's called a global care network with some of the best movement disorder centers across the entire world. This is about 75 centers, so we were very proud of that. So thank you guys for your support, and hopefully we can continue to help you guys with some of the backing from the Parkinson's Foundation. I wanted to mention that, one, because we're very proud of it, and two, this is a team effort, and we actually had a ceremony a couple weeks ago, and I'm royally messed up. I forgot to recognize one very important person, and she's supposed to be in here, so I hope she is. Cindy Payne-Smith, is she in here? Great. Okay, I am so sorry. She is a fantastic clinician. I'm sure most of y'all have had the privilege of working with her. She's always filling in gaps for us, so I am so sorry. Please give her a round of applause. So thank you. All right. With that being said, just like our designation, it's a team effort to get something like this going. I very much want to thank Susan White, our outreach coordinator, and all the people at the Cole Center that pitched in to make this day possible. So I want to thank our speakers, particularly the ones that came from out of town, Dr. Akbar and Jimmy Choi. Thank you for your time and effort in doing this. We very much appreciate it. And then I want to thank our sponsors, particularly the Parkinson's Foundation. We really couldn't do what we do without them. They have now supported us for the 4th year. We have some industry sponsors. Our gold sponsor was Supernus Pharmaceuticals. Our silver sponsor was Boston Scientific. And then our bronze sponsors were Acadia, Accorda Therapeutics, Medtronic, and then Kyowa Kirin, who does Norient. So they have tables out in the lobby, so please look at those. I'm about to get started, but by the way, is this too much feedback? Is this okay? Okay. I have some housekeeping things very quickly that I need to make sure I go over. Most important, I think, for everybody is bathrooms. So if you go out the door, go up to the main lobby and take a left. It's down there on your left. So left, 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 and left. If you get lost, ask someone up there at the front that works for the Cole Center. We can direct you. And certainly if you need any help, please ask. We have pre and post tests that should be on your tables. For those who are joining us virtually, hopefully they got sent out to you. These are very, very important for us. They help us know whether or not you're taking in the information we want. Please fill out this pre-test now if you haven't already. We will have the post-test after each lecture, so please answer those at that time. If you're virtual, we'll be sending out emails with those post-test questions there. Folders. If you are virtual, all the information in the folders should be in the toolbar at the bottom of the main virtual page. Please look at those folders if you're here live. We have a lot of good information in there. Our agenda, the speaker bios, a list of our sponsors, some of the listing of the support groups around the Knoxville area, some of the things that the Cole Center is doing. There's also some information from the Parkinson's Foundation, including some exercise recommendations. And then finally, we have feedback forms. Are we sure this? Okay. Okay. There's also feedback forms. The feedback forms are also very important to us because we want to tailor our symposiums and our educational seminars for what you guys want and need. I think that is the main stuff. Oh, finally, questions. If you're virtual, Please send your questions into the chat. We will collect them. If you are live, there are paper on the tables. Please fill out your questions. We'll have a question and answer session at the end. So with that, I think I'm going to get started. Can someone load up my PowerPoint? I'm going to try and do this with my laptop so I can actually see. Let's see if this works. Okay, I'm not going to do that. All right. So I'm starting us out. I'm doing an introductory talk on Parkinson's disease. I base this off of a lot of the questions that I get in clinic. I've titled this Parkinson's 101, which is Introduction to Parkinson's disease. So conflicts of interest, I have none. I haven't done any consulting in over the last 2 years. I do use a couple slides from a colleague of mine from the University of Kansas, and I'll note those later in my talk. So these are my questions. If you haven't done so already, again, please answer the pretest questions. One of them is about the chemical that's deficient in Parkinson's disease, and the other is about what type of testing we do to make a diagnosis. So hopefully if you don't know these answers already, you'll pick these up from our talk today. So there's quite a bit of information out there about Parkinson's disease, so this is really the 30,000-foot view, so it is very much an overview. So this is an overview of my talk. I'm going to talk about history and basic facts with Parkinson's disease. I'm going to talk about some of the causative factors and start of the disease, how we make a diagnosis, some of the treatments that we have available, and then some summary points. So Parkinson's disease was first described by James Parkinson in our literature in 1817 in his essay on the shaking palsy. This is how we obviously get the name Parkinson's disease. There is quite a bit of literature out there now about Parkinson's disease, and there's even journals now devoted to Parkinson's disease. Before I do any type of talk like this, I always like to do what's called a PubMed search, which PubMed is our electronic database. And when I did one before this talk, we had about 160,000 articles on Parkinson's disease. So there's a lot out there. So basic facts with Parkinson's disease. So there are estimates that close to 1 million people in the United States have Parkinson's disease and about 10 million across the world. This is what we call the second most common neurodegenerative disease behind Alzheimer's disease. About 1 to 2% of the population are around 60 do suffer from the disease, and our overall numbers are increasing. We don't totally know why that is. There's a lot of theories out there. One is that our population is getting older. Another one that I ascribe to is that there's a lot more chemical exposures in the environment, which also probably contributes to the increase in the disease. As I said, this is a disease as people get older. The average age is around 60, but this can vary quite a bit. You can see people that are a little bit older than that in their 80s to 90s. You can also see people in their 40s to 50s, and even younger, younger than 20. Those people we usually call juvenile onset Parkinson's, and those tend to be more purely genetic than what we call idiopathic or garden variety Parkinson's disease. In terms of sex and ethnicity risks, men are more likely to get Parkinson's disease than women. Their risk is about 1.5 to 2 times more likely or higher than women. Ethnicity studies do vary. They vary considerably by the geographic area, but whites or Caucasians tend to be a higher risk than other ethnicity groups. To be honest, though, we need more data on minorities and things like that to have a clearer picture of what's going on. So what increases your risk and what do we think lowers your risk? A lot of these are big population studies. I have in bold their age. That is the highest known risk factor. Gender, again, can also increase your risk. Exposure to different things in the environment like pesticides and herbicides. Also solvents and heavy metals. And then rural living and well water, which is probably associated with some of those chemical exposures, seems to increase your risk. We've also seen some association with head trauma. In terms of what will decrease your risk, exercise, which hopefully you get hammered that into you today. You gotta exercise. That is one thing that will decrease your risk. Caffeine seems to decrease risk, and smoking. I would not advise you guys to go out to smoke. It does have other health issues, obviously, but in our large population studies, it does seem to decrease risk. And then there's a question of higher uric acid, and they've actually looked at that in studies as well. There's some conflicting data about anti-inflammatories, statins, which are cholesterol medicines, and even vitamin D. So what causes Parkinson's disease? What's going on in the brain? The short answer is we don't know what causes Parkinson's disease, but we do know what's going on in the brain. Dopamine production, the cells that make dopamine are actually dying off, particularly in an area of the brain called the substantia nigra. So if you look at this illustration here, you see that dark streak. That's the substantia nigra. And the picture there on the right is a normal brain. If you look at the picture there on the left, that streak is very much faded. So those dopamine cells are dying off or have died off. And that's what's going on with Parkinson's disease. So again, the short answer on why those cells are dying off is we don't know. It's likely a combination of a lot of different factors, including genetics and environment. And then on a smaller level, on a cellular level, there's theories that a lot of things are going on. And I personally believe that it's a combination of a lot of different factors, and it's probably different in different individuals. But one thing we see is these inclusions called Lewy bodies that are made of this protein called alpha-synuclein. We're not totally sure this is the driving force for Parkinson's. Oh goodness. It may be secondary to other causes, but it is certainly something we worry about, and there's a lot of research on. In terms of other things that could be going on, we see a buildup of toxic substances in the cells called oxidative stress. We see problems with cellular function, with cleaning the cell, with energy production in organelles or parts of the cell called mitochondria. We see problems with normal cell death and recycling of cells when they're not functioning right. There's changes in the immune system and possibly inflammation, either from the gut or for prior infections. So as I mentioned on the prior slide, one of the things we worry about is these inclusions when we look underneath a microscope. And so if you look at that picture there at the bottom, that's the Lewy body that we see. And it's composed of this protein called alpha-synuclein. We don't know if this is the driving force in Parkinson's disease, but a lot of people, again, are studying it and are worried that this is the problem. I don't want you to look at this slide and try and figure out what's going on, because we don't totally know what's going on. But I want you to know how complicated this is and how frustrating it has been for investigators. All these cellular processes seem to lead to Parkinson's disease. And so again, I think it's a combination of a lot of different factors. But just know this is a complex issue that we're trying to deal with and figure out. So another question I get all the time is, when does Parkinson's disease start? By the time people show up to our clinics and have things like tremor or walking problems or stiff, we think that Parkinson's disease has been going on for quite some time, probably decades. And some of the things that we've associated with harbingers of impending Parkinson's disease are some of the things I've listed here. So acting out dreams, or what we call REM sleep behavior disorder, is the most common, but loss of smell, constipation, cardiac changes, depression, all these things we associate with potential risk factors for later Parkinson's disease. So what does that mean? So we think that the pathology in Parkinson's disease starts in the very low parts of the brain in an area called the brainstem, which is connected to the spinal cord, and then it progresses up through the brain. When you get to stage 3 and 4, that's when we start having the clinical symptoms that bring you into a clinic. This is called the Brock hypothesis, and this is a very famous hypothesis in the Parkinson's world. What we're recognizing now, though, in the last 15, 20 years or so, is that Parkinson's disease may not start in the brain. It actually may start lower down in the gut. As I said, one of the harbingers for Parkinson's disease is constipation, and what we've recognized that this alpha-synuclein deposit we just see in the brain, actually it's also found in the gut. This is really an area of research right now, and Dr. Barbu is going to be talking about it in her talk later on. I'm having a hard time. All right, so how does a doctor make a diagnosis of Parkinson's disease? So we make a diagnosis of Parkinson's disease by a clinical exam. We're looking for very specific features when you come into our clinic. So the first thing you have to have is problems with speed of movement, and we primarily assess that by watching you tap. So Parkinson's patients' taps will break down and get really slow. The doctor term that we use is bradykinesia. And then you have to have one of two other features. One can be a resting tremor or a tremor when you're sitting still. Typically starts on one side in Parkinson's and then progresses to the other. And the other is changes in tone. So when your doctor's moving your arm around, that's what we're trying to feel for. Particularly a ratcheting type feel, I like to feel it at the wrist, called cogwheeling. That picture there on the right kind of gives you a cartoon image of what a Parkinson's patient looks like. So they've mentioned a lot of the things that we're looking for, but some associated things that we might be trying to assess is your facial expression a little flatter? When you walk, there's very characteristic Parkinson's features where patients are a little bit more bent over, their affected side doesn't move as well, their arm swing tends to be decreased. And we look at your balance. So particularly as your disease progresses, you have problems with your balance and your fall risk goes up. There is some more evidence for Parkinson's disease for a diagnosis, but again, these tests are not diagnostic. These are just supportive. So there's something called a DAT scan. And there's a lot of other tests, but one of the things we do here at the Cole Center is also a skin biopsy that Dr. Barbu brought from Arizona. So this is what a DAT scan looks like. There's a lot of different cuts, but this is just a one cut from those. If you look at the illustration there on the left, the control is a normal person. And that orange and yellow area is nice and full. If you look at the one right over there in the middle, that's an essential tremor patient. So those patients don't typically have problems with dopamine production, which is what these DAT scans are looking at dopamine uptake. And so that also one looks fairly normal. If you look at the one there on the right, that's a Parkinson's disease scan. And if you look at the bottom of the area, it's kind of tapered off. And so it's not nearly as full as the other one. So that's what we're looking for. So this lets us know at least we're dealing with Parkinson's disease or Parkinson's-like condition. Again, I'll say it one more time, it is not diagnostic of Parkinson's disease. The other thing, again, that we're doing here at the Cole Center is skin biopsies. Dr. Barber does our skin biopsies for us, and we're looking for alpha-synuclein, which again is that protein deposit that we see in the brain, but we also can see it elsewhere. She does 3 small biopsies around the neck, around the knee, and then around the ankle. And if we see alpha-synuclein, again, that's supportive that this is at least some kind of Parkinson's-like condition. So I guess I'm going to say it one more time. There is no blood or imaging test for Parkinson's disease. It is a physical exam, but we do have supportive tests to at least let us know if we're in the Parkinson's world. And this can be very frustrating for patients. Some of you may have heard the word Parkinsonism or atypical Parkinson's or Parkinson's-like or Parkinson's plus. And what we're saying when we have that kind of terminology is that, hey, you have the features that meet a diagnosis for Parkinson's disease, but something just doesn't feel right. Maybe you have some red flags that make us think of a Parkinson's-like condition. Or maybe you're not responding to our main medicines for Parkinson's disease, which would suggest this is not Parkinson's disease. Another frustrating thing is that we're always reevaluating. So when you come into our clinic, we may have said Parkinson's disease initially, but then the second or third visit, we're like, something's not fitting, and we may change the term we use. And so that can be frustrating. It's just, sometimes it can be a very hard thing to diagnose. So these are some of the things that we might use when we talk about your case. So multiple system atrophy is a Parkinson's-like presentation. Typically presents on both sides, whereas Parkinson's typically presents on one side and then progresses to the other side. They tend to have a lot of problems with what we call the autonomic nervous system, which is the nervous system we can't control. So things like blood pressure fluctuation, bladder issues, problems with sexual dysfunction. All of these things can happen in Parkinson's disease as well, but it tends to be a little bit more severe and a little bit earlier with MSA. The other problem is they don't respond nearly as well to medication. You might get an initial benefit, but it usually tends to taper off, or you may not respond at all when we start the medication, and that makes us worried. Dementia with Lewy bodies is patients that come in with significant cognitive problems at the same time they have their motor symptoms. We use an arbitrary 1-year rule of when the motor symptoms and when the cognitive symptoms start at the same time. We usually call it dementia with Lewy bodies. Those patients tend to be a little bit more sensitive to medications. They have a lot of hallucinations. They also can act out their dreams, much like with Parkinson's disease. Progressive supranuclear palsy. This is a condition also tend to be both-sided at the get-go. They have a lot of problems with the midline. The classic thing we're looking for is problems moving the eyes up and down, and they have a lot of early falls. Cortical basal degeneration is a nasty one. This one can also start one-sided like Parkinson's disease, but the affected side tends to have more problems than we would expect with Parkinson's disease. Maybe you just can't get the arm to move the way you want it to. You tell your arm or your leg to move and it just doesn't do it. Maybe it flaps around, maybe it's hitting people. It's just, you can't control the arm at all. A lot of times you'll see very severe twisting or really a lot of contortion in the arm or leg that's affected, and that makes us very worried. Much like I mentioned with MSA, and I think with dementia Lewy bodies, none of these conditions respond very well to Parkinson medicine, or if they do, it's not very long lasting. Some other ones that we might mention to you in the clinic that are concerns for Parkinson's-like conditions are vascular Parkinsonism, basically meaning you have a lot of tiny strokes in very sensitive areas that can cause a Parkinson's-like condition. Normal pressure hydrocephalus, where you have enlargement of the spaces of the insulation spaces in the middle parts of your brain, where you'll have problems walking, you have problems thinking and urinating. And then there's a lot of tremor syndromes that can sometimes look very much like Parkinson's. So essential tremor or something called dystonic tremor, where commonly you have a little bit of twisting in your arm. And then finally, drug-induced Parkinsonism. So some of our psychiatric medicines, particularly antipsychotics, actually block dopamine. It can cause a pseudo-Parkinson's-like condition. So that is something we worry about as well when you come in with a lot of psychiatric medicines. So this is a quick video. I just wanted you to get an idea of what doctors are trying to look for in your exam. So this is what we call a rest tremor. This person is sitting and we're watching the hand to lap. And if you looked at the patient before we zoomed in, that left side wasn't moving. So again, for a Parkinson's patient, if we catch it early enough, usually it starts on one side and then moves to the other. Usually I fast forward this video, but okay. Then this individual, if you can see, her face is a little bit flatter. And when we watch her tap, she's not tapping very well. It's pretty slow. She's having interruptions. She's breaking down. So these are the kind of things that your doctor is looking for when they make that diagnosis. I think we have her walk in a second. I'm sorry, I usually fast forward. But real slow. All right. So this, I'm sure all of y'all have been pulled on in our clinic. I'm sorry about that. But this is what we're looking for. She takes a lot of steps and we have to catch her. So these are that's what we call postural instability. This is a Parkinson's-like condition. This is what we call PSP. And then I just want you to get an idea of some of the differences that we might be seeing. And these are the things that make us a little nervous. Is there any way to fast forward this a little bit? I don't need to hear him. Okay, so we're always checking your eye movements in the clinic. So he moves, he's a little slow, but he moves his eyes back and forth okay. But when you have him try and look up in just a second, he can't look up or down very well. And this, again, is something we're looking for, and it makes us very nervous that this is not Parkinson's disease. Can you fast forward just a little bit more? Can someone fast forward a little bit? Tim, just a little bit. Keep going. I want to get to the part where they're walking. Sorry about that. Okay. I only have 2 buttons. Well, if we could get to it, when you watch one of these guys walk, keep fast forwarding. They're actually hyperextended or bent backwards, whereas Parkinson's disease commonly are bent forwards. And when they try and transfer to sitting down, they have a very difficult time because they can't change their frame of reference because they can't move their eyes. So it's a very different looking walk. Here we go. So you see this gentleman, how hyperextended it is. So Parkinson's patients, again, are leaning over. He just can't move his eyes. And then trying to sit down, it's very, very difficult for him. So they definitely look different, right? And this person having trouble moving his eyes. So we can manually, at least initially, you can manually move the head up and down and overcome the eye movement. So that's what they're doing here. But if they try and have someone voluntarily move their eyes up and down, they can't do it. And this is another guy who's having trouble walking. So just a different looking walk. So treatment. So Parkinson's disease, very broadly, we classify into what we call motor symptoms, which is the movement problems and the things we're looking for in your exam, and non-motor symptoms, which there can be a lot of those, and they run the gambit. So when we go through things like bowels and bladder and blood pressure, that's what we're asking about. We're asking about the non-motor symptoms. Most of our treatments are going to modify dopamine in some form or fashion, and they're really directed at helping the motor symptoms. We don't have as good of therapies for the non-motor symptoms. A lot of what we use is for things that we would use for people that don't have Parkinson's disease. In some cases, when people start having what we call wearing off episodes, where their symptom benefit is not lasting from dose to dose, they can have non-motor symptoms associated with their off periods, and those commonly will respond to Parkinson medicine. So this just gives you an idea of all the things that are out there for Parkinson's disease. So our mainstay is our levodopa formulations. There's quite a few of those out there. I think I left off the segmented tablets that just came out. But these are dopamine replacement. This is what we primarily use. So there is an immediate release formulation, which is our main therapy. There's quite a few long-acting formulations. There is an inhaled formulation, which is a rescue therapy, which is Inbrija, which is out there in the lobby. Then our next one I have on here is dopamine agonists. They can be used as a primary therapy and as an add-on. There's several oral therapies. There's a patch form, and there's even an injectable form and a sublingual form, or something you can put underneath the tongue for rescue. MAOB inhibitors can be primary therapies or add-ons. They prevent the dopamine from breaking down the system. There was 3 right now that we have in that class. Amantadine immediate release has been around for a very long time. It used to be an antiviral medication. We use it in a variety of different neurologic conditions, including Parkinson's. It does have some motor benefit and can prolong levodopa response. It also has a lot of benefit with dyskinesias. And we now have 2 long-acting preparations, and one of the manufacturers for one of them is out there, actually for both of them is out there in the lobby, GoCovery and Osmolex, and they actually have an FDA indication for dyskinesias and also for helping with motor symptoms. Anticholinergics is not something I usually use. It affects a chemical called acetylcholine. It works pretty well actually for tremor, but it can cause some cognitive issues. COMT inhibitors also prevent dopamine from breaking down as easily in the system. And we have 3. We don't typically use tolcapone because of some liver issues, but we have 2 that we do use. And then estradiol, Kyowa Kirin does this one. They're out in the lobby. This kind of mimics how caffeine works, so we think that it has some benefit. And it's used for an add-on therapy to prolong out levodopa response. So again, we have quite a few out there. We also have some procedure options. There's 2 available here in the States. There's also a sub-Q apomorphine pump, which is available in areas outside the United States, Europe, places like that. Both of these are great therapies as your disease is more progressed, when you're having problems with your symptom control not lasting from dose to dose. And so we'll bring these procedures alongside to kind of lengthen out your response and even you out. So one is deep brain stimulation. We use electricity. We put implants in your head in very specific areas, deep within the brain, hence deep brain stimulation. It's connected by a wire down to a battery pack, kind of like a pacemaker. And again, it evens you out. We use it with medication. It's not done exclusive of medication. The other one is an enteral suspension. The brand name is Duopa. It instills a paste form of levodopa, or carbidopa levodopa, from a pump through a tube that we put a hole in your stomach, and that tubing actually goes down into the small intestine, which is where dopamine is typically absorbed, so it bypasses the stomach and some of the problems you have there. And you get a continuous infusion of levodopa, and a lot of the problems we have is kind of the pulse dosing you get when you take it orally. So this negates a lot of those issues. So when we start talking about starting medication, there's not a clear standard of care, so people will often debate when to start. I think anybody would start medication when people start to be functionally limited, but certainly you have to take each case on an individual basis, and you have to weigh the pros and cons of medication. I will say that none of our medications have clearly been shown to stop the disease or slow down the disease. All our medications do at this point that we can prove is that they cover up symptoms. Now, there is some data that's better in some drugs versus others, but these are purely what we call symptomatic medications. Now, my old partner used to always say that we don't see the end stage of Parkinson's disease as much. I think that it's from better care. Medications certainly do help considerably. I think patients are doing better with exercise. So we still see it, but I think patients and doctors are getting better at treating Parkinson's disease. So what are our mainstays in terms of what do we start first? So the first one is carbidopa-levodopa. So again, this is dopamine replacement. I always tell patients the same thing. This is the most bang for your buck. It's been around since the 1960s. This is the best one we have in terms of symptom benefit. It tends to have the least number of short-term side effects, but has classically been associated with more long-term issues like the dyskinesias, the wiggling that some of you guys may be struggling with. We also see more motor fluctuations later on in the disease where the medication is just not lasting as long from dose to dose. Other negatives is it does have to be metabolized, and it does have to be taken multiple times a day. Dopamine agonists tend to have less long-term complications, at least classically, but they can have more short-term complications, so we struggle with those considerably. Also, I guess from a pro standpoint, we don't have to take the medication nearly as often as you do with carbidopa-levodopa, so that is a selling point for dopamine agonists. And then MAO-B inhibitors, from a positive standpoint, they don't seem to have those long-term complications nearly as often. There is also less dosing during the day. Typically, most of them are taken once a day. There is one that's taken twice a day. But the negatives really don't provide as much symptom benefit as you do with the dopamine agonists and with the carbidopa-levodopa. So don't forget non-medication options. So exercise, exercise, exercise. Again, if you take anything from these presentations today, please take in the importance of exercise. But I've listed some other things that I think are really important. I mean, the main thing is you want to be healthy. Good sleep, social interaction is really important. Managing any mood issues, and just overall, again, staying healthy. Manage your other medical problems. Diabetes is something we really worry about. Eating a healthy diet. There's data on the Mediterranean diet being helpful for maybe preventing Parkinson's disease or decreasing your risk. And even when you do have Parkinson's disease, it tends to help as well. So I'm going to give a little bit of a plug for exercise. Again, you're going to be hearing this a lot all day today. But some of the things we've seen: delaying disability, decreasing falls, improving range of motion, improving quality of life, potentially lengthening out life expectancy, improving mood, improving sleep. We're getting a growing evidence that maybe this even slows down disease progression. So again, I cannot stress the importance of exercise enough. Exercise programs do have long-lasting benefits, but they're not indefinite. This is not something you can do and then stop. This is a lifelong commitment. You have to keep it up. There's not a lot of comparative trials, but there are a couple that have been coming out more recently. Some high-intensity exercise where you get your heart rate up a couple times a week really seems to be beneficial. But what I really push is doing different types of exercise. I think that handout you have in your folder is really helpful. This is some of the Parkinson's Foundation recommendations. So again, it really pushes different types of exercise. So the next 3 slides are scientific studies. I don't want you guys to get lost in these. These were comparative trials between 2 dopamine agonists. One was ropinirole and one was pramipexole, and they compared them to levodopa, and they were really looking at short and long-term side effects. These were several-year studies with hundreds of patients. And again, I do not want you to get lost, but I just wanted to point out some things. So if you look at the bars there on the left, this is comparing levodopa to ropinirole. The levodopa is kind of the light blue color, and the red color is the ropinirole. And what I want you to see is that the long-term complications, the dyskinesias and the wearing off, were higher in the levodopa group, but freezing was actually less. If you looked at the bars there on the right, they're comparing levodopa to pramipexole, and again, levodopa is that light blue, and the purple is the pramipexole. And again, dyskinesias, wearing off were worse in the levodopa group, but freezing was actually better. If you look at more immediate side effects in these two big studies, side effects were much higher in the dopamine agonist groups compared to the levodopa group. Levodopa was much better. You look at somnolence. You look at peripheral edema, which is swelling in the legs. You look at hallucinations. All of these things were considerably higher with the dopamine agonist group compared to the levodopa group. Nausea was about the same. Postural hypotension, where you get dizzy when you stand up. That was about the same, a little bit worse in the levodopa group compared to the pramipexole group. So take-homes, again, long-term side effects seem to be a little worse short-term with levodopa. Short-term side effects were better with levodopa. This is another trial that I paid a lot of attention to. This came out in 2014. This was a trial where they compared the three medicines we typically start in an open label fashion where patients knew what they were taking, and they followed them for 7 years. They compared MAO-B inhibitors, dopamine agonists, and levodopa. Patients were started in equal number, and their primary outcome was a quality of life measure. And I think this is really fascinating. If you look at the levodopa group, there were about 514 patients, 218, which is a little less than half, added or switched medication, but only 13 actually switched. 28 stopped medication. That's not a lot. If you look at the dopamine agonist group, this was about a little over 600 patients, 467 added or switched, 134 of those switched. So it's a much higher number, and 218 stopped. That's a third of those patients. The MAO-B inhibitor group, 395 added or switched. That's also the entire group, and 215, which is about half the group, stopped the medication. So what I want you to take away from this trial is that the non-levodopa therapies were less well tolerated, they were stopped more often, and they required additional therapy, typically levodopa. There was some statistical benefit in quality of life with levodopa compared to these other therapies, and again, most of our trials show considerable benefit in levodopa compared to our other therapies. And then, fascinating, the long-term complications actually weren't that different when you compared the groups. So the motor fluctuations, the wearing off, wasn't that much worse in the levodopa group compared to the others. So it kind of argued against the classical convention. And then the percentage of dyskinesias was also fairly similar. So if we get back to what do we start, many doctors may start dopamine agonists or some of these levodopa therapies because of this classical convention of longer-term complications, particularly in people that are younger. When you start getting past your mid-60s to your late 70s and farther on, most people are going to start levodopa. The exception would be in this group of doctors is if your work performance or you're really struggling with function, most people are going to start with levodopa. Then there's others that have a tendency to be more what we call levodopa-centric, where they're a little bit more aggressive with levodopa, and this is their mainstay. And I think all the doctors here at the Cold Center fall in that group. I certainly do. And the reasons are, there's more short-term side effect potential. They're harder to be tolerated. If you look at that PD med trial, you can see how many patients had to stop or switch. Levodopa is better in terms of your benefit. And then the benefit of some of these levodopa-sparing therapies compared to levodopa in terms of preventing or at least slowing down long-term side effects is a little less clear than it was a while back. Things like that PD med trial I showed you in something called the LEAP trial, put that a little bit more into question. And I think overall our treatments for dyskinesias and these motor fluctuations are better. So the concern with levodopa is much less than it used to be. So when you're progressing and we've started a medication and you're on medicine, what do we do next when you're just not well controlled? Well, certainly we can increase the medication that you're already on, but we have all these add-on therapies. If you look back or think back to that slide I showed you before, and there was a lot of them. The main thing, though, is everybody's different. We need a personalized therapy, so we have to weigh pros and cons. We have to look at what type of medical problems each individual has when we make a decision on what to do next. When you start struggling with a lot of dyskinesias or your medicine therapy is just not lasting from dose to dose, then what do we do? So same thing. We can increase your medicine or we can add on medicine. We start thinking about some of these rescue therapies with the inhaled levodopa or the apomorphine formulations as a possibility. but we also really start thinking about these surgical therapies, these continuous therapies, the enteral suspension for levodopa and deep brain stimulation, both of which we actually offer now at the Cole Center. Unfortunately, when we get to the severe end stages of Parkinson's disease, we're a little bit more limited. Patients tend to be a lot older at that point. They're having more non-motor symptoms. Things are just not responding very well to our main Parkinson's medications, a lot of times because things like balance and walking problems are never that responsive to Parkinson medication. At that point, we're really using carbidopa, levodopa, and we're focusing on ancillary care like physical therapy and occupational therapy and speech therapy. And we're trying to look at things that really could harm you, things like aspiration pneumonia or fall risk. My next two slides are on non-motor symptoms. I unfortunately just do not have the time to really touch on this, but there's a lot of them. I think one of the more common questions I get in the clinic is this related to my Parkinson's disease? And unfortunately, a lot of times it is to some degree. Not always, but a lot of times. So just some things you may want to think about when you think about non-motor symptoms. So there's certainly mood changes, depression, anxiety, and apathy. There's problems with cognition that become more apparent as the disease comes on. Thinking problems that actually, unfortunately, can rise to the level of dementia. Impulse control problems where patients become overly impulsive, hypersexuality, gambling, shopping sprees. A lot of these are related to dopamine agonists. Hallucinations and paranoia. We do have actually a medication that is FDA approved for hallucinations and paranoia in Parkinson's disease. That's Nuplazid or Pivansar, and the manufacturer is actually out there. Autonomic changes, so blood pressure drops, temperature regulation problems, bladder symptoms, constipation, sexual dysfunction, problems with drooling, sleep issues, which are really hard to treat. There's a lot of problems with sleep, including the acting out dreams that I mentioned in one of the very early slides. Swallowing problems, loss of smell, changes in your skin where you get a rash and dry, oily skin. Visual problems I've seen. Pain is something we struggle with. Weight changes. And I've even seen some problems with shortness of breath and restrictive lung disease. Some of these can be really difficult. I want to make clear that not everyone develops all these symptoms in every Parkinson's patient. These vary from case to case. So these are some summary and conclusion statements. Parkinson's disease symptoms start long before you come into the clinic. This is a progressive brain disease. I may actually start before we even get into the brain, which Dr. Barbu is going to talk about. I like to call Parkinson's disease a syndrome rather than a disease. As I showed you in some of those earlier slides, there's a lot of things that play a role in the development of the clinical symptoms with Parkinson's disease, and I think they're likely different in different individuals, and are probably a collection of things in each individual as well. I already mentioned this, Parkinson's disease may not start in the brain. Looking forward to Dr. Barbu's talk. Our main treatments are treatments for the motor symptoms, and they're going to focus on helping dopamine in the system. Non-motor symptoms are harder to treat. There's a lot of therapies. Most of them are not specific to Parkinson's disease. These issues are often very under-recognized and also can be quite disabling, so it is something that all of us try and ask about in our clinic visits. Then do not forget non-medication options. I'll say it one more time, you've got to exercise. Then treatment can be complicated. You need a really good team. You need somebody that really pays attention to what's going on in the Parkinson's world. So I'd highly recommend getting at least a movement disorder specialist to check in with it. Maybe once a year, maybe twice a year. You could have another neurologist that's helping you out, but you need someone that knows a lot about Parkinson's disease as part of your team. What's next for Parkinson's? I gave this talk probably 2 or 3 years ago, and unfortunately, some of these things have not changed. We still need a reliable marker to diagnose Parkinson's disease a lot earlier than when they come into the clinic, and we need a blood marker, an imaging marker to follow disease progression over time. We need to better understand the causes of Parkinson's disease. Again, I think it's different in different individuals, which makes a lot of our trials difficult. And we ultimately need new therapies to slow, halt, or stop Parkinson's disease. And I tell my patients all the time, I personally think we're going to see a cocktail approach where we have different medications geared towards different problems, much like you see with cancer. So thank you. That's it. Thank you. I think I spilled, by the way. A couple questions. I guess I don't answer. I will let you guys do those questions. So that's all I've got. I don't know what time it is. Have you guys had a chance to look at them? All right, I don't want to leave you hanging. The main chemical in the brain, I hope you pick this up, is dopamine. And then how do doctors make a diagnosis of Parkinson's disease? So it is not a heart test. We do it by clinical exam. Okay. So I'm going to introduce the next speaker. This is Zach Guza. He has been helping us out for quite some time now. He's a real fixture in the community. I think you guys are in a little bit of trouble because he's going to make you move a little bit. But he always brings a lot of energy, so I'm very glad I went first. So anyway, just a little, in lieu of a little bit of background, he's a certified personal trainer. He's a Rocksteady boxing coach. He's a Power Moves instructor, and he's a Parkinson's exercise specialist in Knoxville, Tennessee. He actually was in the military, graduated from the Air Force Academy, and was a helicopter pilot. When he actually left the military, he did a couple things, but eventually he started getting into Parkinson's disease care and helping with exercise in Parkinson's disease, and this was in honor of his late father, who actually died of Parkinson's disease. But he founded Black Dog Fitness, and which now encompasses quite a few things: Rocksteady Boxing, the Parkinson's Gym, which is an at-home gym, Black Dog Boxing, which is a little bit more high-intensity boxing, and personal training. So, good luck.
that would use the benefits of exercise, but in a pill form. Would you take it? Yeah. So, what are you waiting for? Also, what do you call a fish with no eyes? All right, let's go. You had to know that was coming. All right, what I want you to do first is what you're not supposed to do, is slump. Just go into a horrific teenager texting slump. All right. Now I want you to blow yourself up. Take a big inhale and all the way up to a good, perfect posture. All right, if you're just sitting there watching, let's go. Come on. One more time, all the way forward. Just swamp it out the way you're exactly not supposed to do. All right, blow yourself up, back up, nice and tall, palms forward, shoulders wide, head up. Nice jump. All right, let's roll the shoulder all the way up and around. Back. Shoulders are a huge part of everything. What you do, all the way forward, bring them up, bring them back, push them back. Oh yeah, there we go. Back, forward, bring them up, bring them back, tuck them down. One more time. Here we go. Forward, up, back and down, and leave them there. All right. One arm up, straight up, further up, a little further. All right. Other side up. All right. Up. There's a question in the back. All the way up. All the way up. And down. One more time. Yeah. Okay. If this hurts, don't do it. Pain hurts. All the way up. One more time. Other side. Up. Both of them up. Open them back. Okay. Press them back deep into the joint. Slide them down the wall. One more time. All the way up. This time I want you to go all the way down. Open. Put them up. Open. Back. This is when you wish you would have learned a longer shot. All right. One arm forward. boxing portion. I want you to find somebody in the room you think you can beat up. Not going to do that. All right, let's keep going. One arm all the way up. Let it back down. All the way on. New car. All the way out the other way. All the way out. Big head. All the way out. Both of them out. Hey. All right, relax. Take them forward. Open them all the way out. All right, like a book. Close down to one side. Big central rotation. All right, open your head. Close it back up. Open it back up. Nobody? Close it back up. Open up far as you can. Big scan. And relax. Good. Feel better? Oh, we're not even done. All right, reach all the way across. Left hand all the way over to the right, or vice versa. Doesn't matter. We can do both. All right. Right hand left. Left hand right. Big twist to the center. Right hand to the left. All right, let's do them both. All right, good. What I like to do is call this the shark. I'm going to start calling it. I don't get to come back next year. I've already just admitted that. We're going to call this the vowel movement. All right, you're straight forward. First out to the T. So everybody says T. All right, let's take it. I know T is not a vowel. Take it down to A. Let's take it up to Y sometimes. All the way up to Y. Take it forward, take it up to I. Take it all the way down to lowercase I. Push your hands way back behind you. Stand tall, stand forward. All the way back forward. One more time out to T. There we go. Forward. Down to A. Good. Up. Take it up to Y. There's only like 8 people in here. Come on. Take it forward. All the way up to and down to lowercase I. There we go. All right, the legs have not had anything to do. If you want to stand up, please stand up. If not, that's okay too. Not everybody. Take it easy. All right, let's go knees up. Just knees up. Give yourself a little bit of room. Knees up. You don't have to stand up. Knees up. You can do this. Knees up. 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 All right. Put up your dukes. Climb the ladder. Keep going. All the way up. All the way up. Huh. Huh. 10. 9. We're going to be here all day. You better start counting. 1. 2. 1. There's always somebody who goes, 1. All right. Butt kickers. So I want you to kick your heels up like you're kicking your own butt. Heels up, bring them up. Bring them up, heels up. Wide stance. One of the worst things you can do is step on your own feet here. I want you wide stance, like the whole room's rocking back and forth like a ship. Here we go. Rocking back and forth. Put up your dukes. Reach, 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 reach. A lot going on. Reach, reach, reach. 87. Sorry. Go 10, 9. Good effort. 8, 7, 6, 5, 4, 3, 2, 1. One more time all the way up. And just fold it over nice and easy. As far as you want to, as far as you're willing to, just hang it out. Not a stretch, not a push, just hang it out easy. One more time, all the way up. Big inhale. All the way up. And all the way down. Phew. All right, back up nice and tall and proud. That's what we got. Feel better? See? That's like our warm-up in Rock Steady. So, the stuff works. treats Parkinson's. So what are you waiting for? Right? We'll see you out at Black Dog Fitness. Thank you. What's next? No break. Get back in here. No break. All right. No break. Come on back.
Hey, we don't have a break. I'm going to try and clean up this water, though. I'll be right. We'll get right with you.
Testing, testing, working.
Yeah. It looks like people are going in and out. I'm going to start in about 2 minutes. All right, I'm going to get started. Can everybody hear me? Tim, could you turn the music off? Could you turn the music off? Thank you. I have the pleasure now to introduce Dr. Zayas. Dr. Zayas is one of the Cole Center movement disorder specialists. He has actually now been with us for almost a year and a half. He, in addition to his clinical responsibilities, he's also the head of our outreach, and he's done a wonderful job. He's a great speaker, so you guys are in for a real treat. He is going to talk about some of the things that your doctors want to know about your Parkinson's disease when you come into the clinic and when you come into the hospital. By way of background, Dr. Zayas actually started as a physical therapist, He started his training in Puerto Rico, then did his medical school in the Dominican Republic. Soon after, he came to the States, and he did his medicine residency at St. Barnabas Hospital in Bronx, New York, then a neurology residency at Cooper University in Camden, New Jersey. Then he's done several fellowships, including a neurocritical care fellowship at the Cleveland Clinic in Ohio, and a movement disorders fellowship at the University of Nebraska in Omaha, Nebraska. So please welcome Dr. Zayas.
Testing, testing. Well, a lot of people here, wow. So, today, I'm not going to talk about exercises. I'm not going to talk about physical therapy. You guys are tired of me talking about this. By the way, I do exercises. Actually, I met Jimmy Choi in one race a long time ago. I think 3 years ago, 4 years ago in Illinois. So, but this time we are going to talk about something less painful. Less painful, okay? But again, I still do exercises. So we are going to talk about how to prepare for doctor's visit and hospitalization, which is a concern that we have. No disclosures. These are the questions that you guys should have in the pamphlet. Hopefully you have the chance to answer this question, and then we will go over the question later, okay? Now, this is not working here. Okay, so these are the questions that we are going to answer today. Number one is, what does your Parkinson doctor need to know to improve your quality of life? I mean, what do I need to know as a Parkinson doctor to treat you better, to have better outcomes so we can improve your quality of life, which should be our goal. The next question is how to use your face-to-face encounter more efficiently in the clinic and to make the most of it. And number three, which is the most important question, I think, is what we can do to increase the probability of you surviving a hospitalization when you have Parkinson's disease, especially when you have advanced Parkinson's disease, which is a big concern. Because remember, we do not have control of whatever happened in the hospital. We have some control of what is happening in the clinic, some control, but we don't have any control of what happened in the hospital. So it's a concern, okay? And we share this concern. So why this is important? Why we are so concerned about that? Number one, because the data show that when you compare patients with Parkinson's disease and without Parkinson's disease, patients with Parkinson's disease stay more time in the hospital, longer stay. And when they are going to be discharged, they usually go to the acute rehab because they have generalized weakness, deconditioning, so they end up going to acute rehab. I'm going to talk about why this is happening and what we can do to prevent this problem. Question number one, and I'm going to divide this question in two. What do I need to know as a Parkinson doctor, and what are the resources for you to learn more about Parkinson's disease? So this picture represents what we are. We are human beings. So which means that we have the capacity to communicate better than any other species on the planet. But we need to improve that. We need to improve that. And we can. And that goes to both ways, physician or providers to patients and patients to providers. The most important thing is that you need to be educated about symptoms of Parkinson's disease, okay? Very important. You need to get education about Parkinson's disease. This is the first step. When you know something, it's going to be easy for you to explain how you feel. And also help me a lot, save me time, misunderstanding. And that's why actually I have a YouTube channel that I teach Parkinson's stuff, because that helped me, that saved me time. And it's very important. So imagine that in Parkinson's symptoms, the symptoms are divided in two parts. And Dr. Tolleson was talking about that. So we have the motor symptoms, right? And I want you to visualize these as an iceberg, okay? The top part, the top is what you see. Everybody see. Everybody pay attention to that. Doctors are looking at that because are the things that are visible. The thing below the water is the things that we don't see. So everybody knows that tremors are common in Parkinson's disease. Not every patient have tremors, okay? There are probably 25% of the patients that they don't have any tremors at all, okay? But tremors is one of the features that people say, oh, he might have Parkinson's disease, okay? Because it's more visual. Then everybody, in order to have Parkinson's disease, you need to have a slow movement. Otherwise, you don't have Parkinson's disease or not yet. But you need to have a slow movement. It's a requirement. And then you have the stiffness, which is the rigidity, and balance issues. But not everybody has rigidity, not everybody. And then the most important part is the lower part, because this is the part that affects the quality of life of patients. This is what really affects your life, which are the non-motor symptoms, things that we don't see, and they are important. And there are many, because every single system in your body will be affected. Every single system, in one way or other, directly or indirectly. Even the skin is affected, okay? So, these are the topics that we need to address or at least to try to discuss in every visit. This is the questions that I might be asking you, and if I don't ask you, and you or your loved one are suffering from one of them, speak up. We need to know. Why? Because we have treatment for that. We have treatment. At least we try. So, psychiatric symptoms. I need to know if you are having psychiatric symptoms. So, I'm going to talk about the most common one. For example, hallucinations is one of them, and delusions. Hallucinations is seeing things that nobody else is seeing, okay? Delusions is like believing something that is not real. Like one of the common one is infidelity. Okay, I see this a lot. Infidelity. It's not real, but you're still thinking about that. You're still thinking about that, and he's doing this, and he's doing that, and I see that boom, 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 all the time. Okay, so depression, anxiety, apathy. Apathy is so common. And not only in Parkinson's disease patients, in many of the neurodegenerative diseases that we treat. Apathy is a lack of motivation. Your husband, you tell your husband, let's go to Florida for vacation. No, I don't want to. You go, you stay. That kind of things. They don't have the similar motivation that they used to have years ago. Why that happened? We are not sure. We are not sure. We are not clear about what is happening. Could be related because you are depressed? Yes, but not necessarily. You can be depressed, but maybe you don't have apathy or vice versa, okay? Could be because you have some cognitive issues? Yes, too. It might be related with cognitive issues as well, but not always, okay? Impulse control disorder. This is a common phenomenon, and especially when you look for that, okay? Because if you don't ask, patients are not going to tell you this. They don't tell you this. This is the kind of things that they don't want to talk, okay? And actually, the medication that we prescribe might be causing this, exacerbating this problem, okay? Many of the medication that we prescribe. I'm talking about the dopamine agonist, pramiprazole, and the patch, the Nupro patch, and even the levodopa might cause that too, but less. So it's a very common phenomenon, and we need to ask, okay? Cognitive thinking problems, okay? When I say, I always ask memory, because memory is what people think about cognitive problems. But memory is one of the domain, one of the areas of cognition. And it's actually the simple one. They are more complex. For example, language. How many languages do you speak? So that's another level. How do you find yourself in the space? Okay, if you are getting lost, how do you go to point A to point B? Following instruction, following a recipe. This is what really in Parkinson's disease get affected first. Okay, not too much the memory, and that's why when we ask if the patient have memory issues, no, memory is okay. Yeah, memory is okay. But what about the other part? Okay? The other part is what is get affected the most. Autonomic dysfunction. Okay? When I say autonomic, I mean it's part of the nervous system that control your internal organs. Okay? We don't have it's auto. So we don't have control of that. Okay? We don't have control of the heart rate, even though that there are some patients, some people that they have some control of the heart rate. But usually we don't have control of that. So one of the most important things is if you feel lightheadedness when you stand up, dizzy, lightheadedness, dizziness can mean many things in neurology. But when you stand up and your dizziness or lightheadedness is only when you are upright, that might be a blood pressure related. Okay, and this is part of the autonomic function. So typically we have control of that, so the blood pressure improves, but in patients with Parkinson, especially in an advanced stage, and not necessarily, I have patients also during the first 5 years that have this problem too, they might be having syncope. Syncope means transient loss of consciousness. They pass out, fainting, because the blood pressure drops, okay? So we need to know about that. The other ones are constipation, urinary urgency, so those patients that need to go to the bathroom multiple times a night. So imagine that you wake up 5-6 times a night to pee. You're not going to sleep. So we have medication for that. You need to tell me, because we have medication for that. By the way, you need to be careful. What medication do you use? Because some of the medication might affect your mentation, some of them. Fecal incontinence might happen to some patients. Eat and they feel full. They eat a little bit and they feel full. Okay? That might happen in Parkinson's disease too, and it's part of this system. Problem swallowing, drooling. Okay? Drooling is very common. Sometimes we don't need to treat that. Just an acting would be enough, but some patients require treatment because it's very severe, right? And if the drooling is affecting your social function, so we need to do something about it. Sexual dysfunction is also common. Excessive sweating also is common too. Now, sleeping. Sleeping issues is almost always present, okay? Almost always present. Almost everybody, I think the data show 98% of the patient, they have a sleep fragmentation, which means that you wake up multiple times a night, okay? And by the way, you don't need to have Parkinson's disease to have a sleep fragmentation. This is a very common phenomenon in the general population. Acting out during sleep. Acting out during sleep means that you are punching, kicking, moving a lot, screaming, having vivid dreams, and not good dreams, very bad dreams, unpleasant. You are chasing somebody, somebody's chasing you, you are fighting, and you think that it's real, and you actually can punch. I have a few patients punching walls with a fracture, okay, punching a wall. That's extreme, so it could be very bad. I'm punching the wife. Yeah, so that happened. We have treatment for that. Also RLS, restless leg syndrome, very common phenomenon. We don't know if this is part of the package or we are making the RLS worse because we give dopaminergic agents to those patients, like levodopa, and that might exacerbate the symptoms of RLS. We don't know why. If before blaming Parkinson's disease, when you are sleeping too much, like falling asleep now, wake up, falling asleep, and you are snoring, make sure that you rule out the sleep apnea, okay? Rule out the sleep apnea. Every patient with daytime sleepiness, excessive daytime sleepiness, before blaming, oh, this is Parkinson, this is the medication, this is the dopamine agonist, you need to rule out that. Why? Because sleep apnea is highly associated with many other health issues, such as heart attack, strokes, arrhythmias, memory issues, okay, depression, becoming cranky, okay? So all these things, and easy to treat. Easy to treat. Well, I don't want to say easy to treat because you need to use a machine, right? But there are different type of machine. Now, this is 2022. We don't have the big mask. Now it's small. And you don't have the noise of the machine that you used to have before, okay? So try to get sleep study. And the sleep study can be performed at home. Actually, medical insurance prefer that. I have to be careful. Like that, okay? Because it's cheaper. And one detail, because I want to tell you this. My grandma got a sleep study because she snore, but it's amazing. It's amazing. And then she has daytime sleepiness. And the study was negative for sleep apnea. How come? This is not possible. And I asked her, she didn't sleep during the test. So if you don't sleep during the test, how come you would diagnose that? So just be careful when you get the result and it says you don't have a sleep apnea. That doesn't mean that you don't have sleep apnea. The thing is that you didn't sleep. So I asked one of my friends from Illinois, who is a sleep doctor, what can we do for her so we can capture her sleep? He told me, give Ambien before, because Ambien is not going to affect the sleep pattern, okay? Because I thought that giving Ambien is going to affect the sleep pattern. No, give it Ambien. She needs to sleep so we can capture that, okay? This is a detail, very important. More important question, falls. So everybody has a fall. If you check, I have multiple scars, okay? Because, I came from Puerto Rico and we used to climb trees and all this stuff, so I have multiple scars everywhere. Falls is important because before blaming Parkinson, we need to rule out other causes that might predispose you to have falls. For example, neuropathy. It's very common when you get older to have sensory disturbance because your nerves are not working well. The information coming from this area to your brain not working well. So we need to rule out prediabetes. Prediabetes means that close to be diabetic, or diabetes and vitamin B12 deficiency, very common in Parkinson's disease. We don't know why it's so common in Parkinson's disease. I don't know if it's because there is some problem with the absorption, but it's common. And if you don't correct that, the neuropathy will get worse. So this is very easy to check, okay? Now, other reason is, maybe you are undertreated, so which means that you are not taking the correct doses of medication. You are undertreated and you might need a little bit more gas in the tank. So when I say gas, I mean the levodopa tank is the head, the brain, right? So we might need to check for that. Eyes problems, so go to the eye doctor. Maybe you need some glasses because you're falling down, right? You cannot see well and you will trip. I always say be careful with small dogs, okay? Nothing against dogs. I have 3 dogs, but they are big. They are German Shepherds. So every time that I ask a patient, I will tell you 40% of the time there is a dog involved, okay? And usually it's a small dog. I'm just saying. Other things to check. But before I forget, sometimes we need to send the physical therapist or the occupational therapist to evaluate home safety at home, because this is a professional that are trained to identify hazards. So things like, oh, this should not be there because you will fall. Okay, they can teach you, they can remove and educate you things that you should not have in this particular place. Important, these are professional. The other thing is making sure that you are not falling down because your blood pressure is dropping, okay? Very common thing that happens, that we blame the balance, the wearing off, the dyskinesia, other stuff, but did we check the blood pressure? Because maybe this is the reason why the patient is falling down. Sometimes when you get older, you don't have the similar symptoms that patient 20 years old, 30 years old will have, the lightheadedness. No, patients at 70, 80, they don't feel like they're going to pass out. They actually collapse without any warning sensation, okay? Now, motor complications. So with the years, you will have this, okay? Everybody will have this with Parkinson's disease. Otherwise, you don't have Parkinson's disease, you have something else. When this is gonna happen, every patient is different, okay? And also depend how much exercises do you do, right? Exercises is key. Again, I'm not going to talk about exercises, but it's so important. So you can have dyskinesia. Remember to know the difference between dyskinesias and tremors. Why? Because when you call the office and you say, my tremors are worse. My tremors are worse. Okay. So your tremors are worse, that means that you are off. Let me increase the levodopa. And then she called back. My tremors are even worse. And they send me a video. And when I see the video, there are not tremors. It's dyskinesias. So I was giving the incorrect advice. Why? Because you told me tremors. You didn't tell me dyskinesias. So usually the treatment is different, okay? But not always. Parkinson's disease is kind of complex, so you have to be careful with that. All of these motor complications, is there any relationship with levodopa? We need to know, because we can adjust the levodopa. We can modify the way that you take the levodopa to improve those symptoms, okay? There are many things that we can do. Do you have any recent surgery, any ER visit? We need to know that. Are you taking any new medication? We need to know if you are taking any new medication. This is one of the questions that my nurse will ask you. And I hear that because I'm close, so I can hear when she asks, are you taking any new medication? And I see that she writes a new medication, okay? Very important. And if she doesn't ask you, tell her, okay? Because sometimes she forget. Resources. So this is my personal opinion, okay? My personal opinion. There are many. I like this. I like Parkinson Foundation. The website is very nice. The same thing with this American Parkinson Disease Association. Very nice website, very clear. David Finney, I like this also. Very nice, very clear website, a lot of information. And Michael J. Fox Foundation, of course. And also, I like this book a lot. Very simple to read. This is what you need to know in a simple way, okay? For care patients, and I recommend this book. This is my opinion. This is the best book that we have for patients, and I read. Obviously, you guys know that I have a YouTube channel, basically Parkinson disease stuff, okay? The short videos. Now, how to use your face, this is the second question. How to use your face-to-face encounter more efficiently in the clinic and make the most of it. The first step is be on time. Yeah, and we always recommend to be 10 minutes before. And you might be mad because, well, the doctor told me to be 10 minutes before, but he came 10 minutes late. Yeah, that might happen, I understand. Yeah, sorry for that. But try to be on time. Why? Because otherwise you will cause what we call a domino effect. So you might start affecting other patients. Remember, there are many patients with the same problems after you, okay? And maybe more problems. So Parkinson's disease is very complex because it affects every system. So I see patients with epilepsy Friday, and the complexity never compare. So epilepsy, I have shorter time because I don't want to call it too easy, but technically yes. Compared with the PD patients, PD patients require more time. Have a medication list, please. I know sometimes it's difficult, but if you have a medication list with you, with the doses, that help us a lot. Because I take that paper and I go over that, okay? This is the first thing that I do. You know me. This is the first thing. I check how much of medication or levodopa you are taking because I need to know. I don't care if the nurse asked you before, I will ask you again because I need to make sure about that, okay? Now, please, don't bring this. Patients think that I know the colors and the form. I don't have any idea about the color. I'm telling you. And my partners don't know anything about it. You know something about the color? No. The only colors that you know is this one. Yeah? Why? Yes. Why? Because we challenge patients in the hospital, well, the hospital too, in the clinic with levodopa. So this is the Cinemet. And it's a 25/100, which is the one that I use, and my partners use too. So it's yellow because I see that a lot. That's the only color. Don't ask me, oh, it's the blue color. Blue pill. Blue pill. Are you talking about Viagra? No. So this is the kind of thing. So don't bring this. Any side effect of those medications. This is very important to have side effect of medication. Oh, I need to know the side effect. Do you have any? During the appointment, what to do? Okay? You are in the appointment. Be honest answering the questions. Okay? Be honest. I know people with Parkinson, they try to minimize symptoms. There is something that we call the personality, Parkinson personality, which I love it, by the way. Yeah, that's why I work with patients with Parkinson. They want always to make the doctor feel well. But that's not your job. That's not your job. So patients don't complain, but the caregiver complain. The wife complain. Okay? And they look at, tell the truth. Okay, whatever, you know. So please speak up. Speak up. Bring your partner with you. Okay. Try. If you can, bring your wife, your husband, your partner with you. This is important because they will give me more information. Okay. Now, have a list of questions. It's not possible that you. Okay, let me ask this to the doctor. You will forget. I'm telling you. Why? Because I start talking, okay? And you need to stop me, by the way. Don't feel bad. If I'm talking too much, stop the doctor. Okay? It's your time. You are paying for that. Okay? So it's just don't stay with a doubt with the question. Just ask the question and have the list of questions. Ask the common side effects. Okay? If the doctor is going to prescribe a medication, so what side effect I need to expect? Okay? For example, I'm going to start you on Cinemet, which is the yellow pill, right? The only pill I know color-wise. So the main side effect is feeling sick, nausea, right? Feeling sick. Up to 20% of the patient usually goes away, but not always. There are some patients that continue having nausea, and we need to find a way for them to take the pill. Because there is nothing better than levodopa. Still, 2022. Now, the last question and the most important one. Okay, how can we increase the probability of you surviving a hospitalization? And I'm talking about hospital safety here. Okay, hospital safety. We are very concerned about that because many things happen in the hospital, and we don't have control of that. Yes, if you go to UT, yes, we have communications. But if you go to another place, rarely. Okay? Yes, I have received calls from hospitalists calling me because they have a question. Okay? And I say, wow, this is a good doctor. This is a good doctor because not everybody would do that. Okay? So the first step is avoid hospital. Don't go to hospitals. And you say, what? This doctor is telling me that? Yes, I will tell you why. There is a few exceptions to the rule, right? And I call the 6X, okay? You need to know this because this is important, okay? If know about stroke symptoms, if you have symptoms suggesting a stroke, don't even call your doctor. No, you call 911. You don't play games with this because the outcomes depends of how fast you go to the ER. Okay, this is very important. So know about, just Google it. Okay, be careful with Dr. Google. Be careful with that. But try to get information about the symptoms of a stroke. You need to know that. Also, if you have acute chest pain or shortness of breath, that might be a heart attack. Okay, don't wait the next morning. Just call 911. Chest pain, they know what to do. If you have a fall and you hit the head, and you lost consciousness, and you're having headaches, or you're having a hip pain after having a fall, don't wait the next day. Call 911 because you'll most likely have a fracture or you have a bleed, either or. Okay? Don't play games with that. Allergy reaction. This is less common, but it might happen. Swelling, shortness of breath. Ooh, you need to call 911, okay? Also, suicidal ideas. This is not common in patients with Parkinson, but might happen, and this is an emergency too, okay? Seizures. New onset of seizures, you need to go to the ER. If you have history of seizures, and you're having a breakthrough seizure, and you're back to baseline, and you have any trauma, it's okay to stay at home. Just inform your doctor, okay? Why to avoid hospitals? Well, improper medication management and lack of hospital staff knowledge. That's the concern. That's the main thing, okay? This study that you guys see here was published in 2015, showing that 38% of the patients, they received the medication on time. Okay? No problems. But 33% of the patients did not receive the medication at all, for whatever reason. They don't receive the levodopa. No levodopa for you. Okay? That happened in the hospital. And there are multiple study, data review, short review, showing similar numbers, okay? 1/3 of the patient, 25% of the patient, they stop the levodopa. And I will tell you what might happen if you stop the levodopa like that. Okay, I will tell you soon. Interestingly, 21% of the patients receive medication that are considered contraindicated in the setting of Parkinson's disease. And most interestingly is that 70% of the staff, they didn't even know about that. They don't have any idea that this medication is contraindicated in the setting of Parkinson's disease, but still the patient is on that medication. Okay, that happens frequently in the hospital. Frequently, believe me. There is I'm going to continue talking about why to avoid hospital. The second one is because increased chances of having delirium, acute confusion. I'm going to talk about delirium soon. The hospital stay is longer, like I mentioned before, approximately 2 weeks longer than all that non-Parkinson patients, okay? Remember, Parkinson patients also, they have other diseases. It's not just Parkinson, they have other diseases too. Lack of care standards. Nobody knows what to do. So it's not the same as a stroke. In a stroke management, you have a protocol. Everybody knows what to do next, okay? In the hospital, for patients with Parkinson, nobody knows what to do next. That's a problem that we have, and that's a concern that we have. Increased risk of fall, okay? This is a very common phenomenon that happens in the hospital too. Now, why do Parkinson's symptoms get worse in the hospital? I will tell you why. Mismanagement of PD medication. PD means Parkinson's disease. So we talk about that, how you get the incorrect medication that are contraindicated, that will make your symptoms worse. Lack of mobility. If you spend 24 hours on bed, you will become very weak. And actually, those many patients require going to the rehab unit to get stronger, and then they can go home, okay? Because this is what happened. If you don't move, you will become weak. The brain, new medication, any medication that block dopamine might affect your function, might affect your mobility, okay? Also, the brain cannot compensate anymore. Before, when you don't have any infection, any electrolyte disturbance, your brain can compensate. But when you get sick, for whatever reason, the brain cannot compensate anymore, so you will see more Parkinsonian symptoms, motor symptoms, like more stiffness. That's why your loved one, when he is infected because he has pneumonia, why his tremors are so bad now? Why he's more rigid now? Well, because of all these things, okay? You can have problem with medication absorption. There are many reasons for that, okay? Your bowel get more affected, so you have more constipation because you don't go to the bathroom at the same time as you do at home. So if you change something in Parkinson, it will affect the whole system. That's why in Parkinson you need to have routine. You need to do things at the same time. Otherwise, things are not going to work well. The same thing applies with exercises. Exercises at the same time, okay? Going to the bathroom at the same time. This is what it is. Let me ask you something. What will happen if you stop levodopa abruptly in the hospital? If the doctor who is taking care of you say, I'm going to stop your 3 pills of carbidopa levodopa that you take 6 times a day, okay? I will stop that. Why? Because you look confused, and you have you look confused, and you have a UTI, and I need to stop that. Okay. Well, this is going to happen. So you go to ICU, and you could die. Okay. So don't. This is the don't. Okay. Do not stop the levodopa abruptly. Why? Why? Because up to 4% of the patient can die from this, especially if you have other issues going on around you. Okay, around you. So if you are a healthy guy with just Parkinson, yes, you will survive that. You might survive that. But a 90 years old guy who had a stroke recently, who has Parkinson, who has cognitive impairment, who has chronic kidney disease, and you do that, most likely is going to die. Okay? It's going to die. Or if he's not going to die, we will have significant morbidity, more problems, more diseases later on, more sequela. Okay? So symptoms of you are developing these are fever, very high fever, not the typical fever that you see in patients with infection. No, high fever, central fever, very high numbers. They become very rigid, okay, very rigid. They become very confused, mostly sleepy more than agitated, but could be both. They can start sweating. The blood pressure goes up and down, heart rate up and down. So that's the problem, okay? Like I say, up to 4% of mortality rate. You don't take this medication, okay? Make notes about this. This is a medication that you should not be taking in the hospital. They are contraindicated. This medication, actually there is a list. I will talk about a bag you can get from the Parkinson Foundation that the list of this medication are there. So this is basically anything that block dopamine. Anything that block dopamine. Remember, in Parkinson, dopamine is low, so it doesn't make sense to block something that is already low. There is some exception to the rule, and there are 2 medications that we can use that less likely to cause more Parkinsonian symptoms are the clozapine and the quetiapine or Seroquel. Okay, clozapine is very difficult to prescribe because require monitoring, close monitoring. So doctors usually actually don't have any patient with clozapine. I don't know if you guys have some patients. So it's a minimal amount of patient because require some monitoring, okay? Now, delirium precaution. This is very important. What is delirium? Delirium is acute confusion. Patients, there is a reduce in awareness and there's some fluctuation, okay? They might be awake, they might be sleepy, they are not paying attention and they are not thinking clearly, but this is acutely, okay? This is not the same thing that dementia, okay? Dementia is something different. However, patients with dementia are at higher risk of developing delirium. Why we need to prevent that? Because it's highly associated with increased mortality, so the probability that you die increased probability that you end up in a nursing home, okay? Increased risk for hospital falls, and actually there is some evidence showing that it might cause even permanent cognitive impairment. And I hear this a lot, that after a very bad delirium episode in the hospital, my dad is not the same mentally. It's a lot, okay? So something is going on. Motor deterioration, we know that. The good news is these are preventable. In approximately up to 40% of the time, we can prevent this. Who is at risk? If you have a prior history of delirium, you will be at risk, okay? If you older patients, many of our patients, they have more than 62 years old, they are more predisposed, especially if you have renal, kidney, or liver failure, okay? Or if you have pain or infection or any type of metabolic process, sodium is low, phosphorus is low, all these things might precipitate delirium. If you have cognitive, mentation issues, okay? I don't want to say memory issues because memory is one of the domain, but cognitive issues. If you are taking some medication that we use to treat you, you are more predisposed to have delirium, such as amantadine, trihexyphenidyl, benztropine. Those are medications that I typically don't prescribe for Parkinson. I don't have any patient on those medications except amantadine. Yes, amantadine, I use it. Narcotics, you have to be careful with narcotics. You need to have a balance. Pain might cause delirium, but also medication that we use for pain might also cause delirium. Benzodiazepines might cause delirium too, but sometimes we need to use benzodiazepines in the hospital when safety is an issue. Sometimes we need to use benzodiazepine because I cannot use the other ones. So we need to have a balance here, okay? Sometimes patients with severe delirium psychosis in the hospital are difficult to treat, to manage. Oh, I forgot to show you, the bladder pills, like I say, there are some bladder pills, like oxybutynin, might predispose patient to have delirium, okay? Some of them. There are a few, like mirabegron, that is not associated with cognitive issues, at least not like the other ones, because they have a different mechanism of action. How to prevent? Well, avoid polypharmacy, okay? Remember, in Parkinson, we don't need to treat everything with a pill. Don't think that there is a pill for everything. There's not such thing. Number 2, a clock or calendar in the room, okay? So try to put something on the wall. Usually hospital, they have that. That might help. Avoid medication associated with delirium, like Benadryl. Benadryl is a common one that people use to sleep because it affects your cognition in susceptible patients. Narcotics, bladder pills, I told you that. Constant reorientation. For example, call Dad, it's 8 a.m. It's time for your breakfast. So say a word, 8 a.m. It's time for your breakfast. You need to try to cause orientation. Is It's almost Christmas. Okay, so if the patient says, oh, it's Christmas, so it's, okay, 23 December. So that kind of things. Wear glasses and hearing aids, okay? Very important. Wear them. So wear glasses. Oh, at home. Oh. Do not change the way that you take your medications, okay? Take the same thing, the same doses, or at least try the same doses. Sometimes we might need to make some adjustment, but at least try to keep the same pattern, okay? Pain management, very important pain management, but be careful which medication you use, okay? Be careful. Frequent staff rooms, avoid that. So having a different nurse all the time, and different rooms, changing from room to room, this is not gonna work. You will have delirium. Even me, I will have delirium too, if you do me too. So it's just, don't do that. Get familiar objects, pictures of your family close to you. So try to make the environment more familiarized with your normal environment. Sleep hygiene, very important, okay? I know in the hospital, they wake you up every 2 hours to check your vital signs. Tell the doctor to review the orders, okay? Many times doctors don't review the orders, and they keep doing vital signs every 4 hours, waking you up. There's no need to that, okay? Just twice a day is okay. Check every 4 hours, for what? I stop that. Every time that I'm going to the hospital, I stop that. I want my patient to sleep. Adequate nutrition and fluid intake. Make sure that you are eating. Make sure that you are drinking water. In the hospital, this is very common. And aerosolization. Move. Don't stay on the bed. Okay, move. Under supervision. Okay. Now, if your loved one, and we are finishing soon, if your loved one already is having a delirium, what you can do. Doctor will be looking for causes, yes, but you can do things too. Number one, you can tell the doctor who is in charge to talk to the Parkinson doctor, to give it a call if they have any clear question about the management of the medications, okay? I receive calls from hospitalists, and this is nice. It's just very quick. They have a doubt, they have a question how they can manage the Parkinson medication because they are expert on that. Okay? And I'm pretty sure they are not going to get mad about that. No. Oh, no. Sorry. Give frequent reorientation again, okay? Frequent reorientation. That is 8 a.m. It's time for the breakfast, okay? 12, it's time for lunch. Seizures. Instead of, if you see your loved one restrained, this is bad. Right? Obviously, patient, when safety is a big issue, we need to do that, right? Your loved one is tired. You see that all the time in the ICU. But if you know your loved one, you can talk with the nursing staff that you will be there close and you will be watching, okay? Sometimes we don't have seaters for everybody, so sometimes you need to help. Just get in there, and you know how to calm down. You know how to calm down him. Okay, so talk with nursing staff about this. Make sure that patient is taking the correct levodopa. Okay, avoid stopping the levodopa. You don't stop the levodopa. I don't see any reason why we need to stop the levodopa. You can decrease, but you cannot stop. Why? I'm talking about levodopa. Make sure that the patient is sleeping enough, at least 6 hours uninterrupted. Every time that I am rounding in the hospital, I put this very big. Please let him sleep at least 6 hours. Bother him. Okay. If you are a smoker or you drink alcohol, let them know because you might start having withdrawal symptoms. Okay? Pay attention to swallowing pro, okay? Now, this is the thing that you need to, you Google this that aware in care kit, and you get this, okay? You had to pay only $8. This is recently, because before it was free. I don't know, apparently this year, they add the shipping, $8, okay? Now, the questions. Hopefully you get the answer correct. Okay? Basically, which one is true so we can prevent delirium in the hospital? Okay? We can prevent delirium in the hospital. And if you feel fatigue, go to the emergency room? No. If then I will be in the ER because I feel fatigue. Take home messages. So learn as much you can about Parkinson's disease. Be on time, please. Be on time. By the way, there are places that if you arrive 15 minutes late, they cannot see you, and this is very bad. Wow. Have a list of your medication, but updated medication with the doses, okay? And if you are in the hospital and you are going to be admitted to the hospital, bring your pills with you. The whole thing. No, don't bring the one pill. Oh, this is the pill. No, don't do that. Bring the whole thing. List of questions, okay? Prepare a list of questions. That might help you a lot because you will forget. Have at least 3 questions, 2 questions, and go over the question with the doctors or the provider, okay? Do not stop the levodopa abruptly. Have the list of medications that are contraindicated close to you. And where you can find that? In this bag, okay? Everything is there. Everything is there, and this is the website. You go there, you pay your $8 because it's the shipping, and you get that. And every one of you with Parkinson should have that. This is a nice. Any questions? Question later, right? Oh, okay.
Thanks, Dr. Zayas. Really appreciate it. I wanted to add one thing to his talk. When you bring in your medicine list, if you could bring the times you take your Parkinson medicine, that is also really helpful. So thank you for a great talk. We're going to have a break until 11, and then we'll start again. And then after that, we're going to have lunch. Hello. We are actually going to get restarted. I think they've started putting out things for lunch. Just so you guys know, after our next speaker, they will be serving lunch to the tables. The desserts and the drinks will be on the side, but you will not have to get up and get food. They will bring it to your tables. And I will remind people when the talk is done. But this next talk is from Dr. Akbar. He's one of our keynote speakers. We're very honored to have him here. He's going to be talking about some of the therapies that are coming down the pipeline for Parkinson's disease. By way of background on Dr. Akbar, his interests are specializing in the medical and surgical management of people with movement disorders. He actually comes to us from Rhode Island. He's the head of the movement disorder program at Rhode Island Hospital and is also an associate professor at Brown University there. In terms of his training, he did medical school at the University of the Americas, and then did a neurology residency at Cooper University Hospital, where he actually met Dr. Zayas. And then he went on to do his movement disorder fellowship at the University of Florida in Gainesville, where many of you may know Dr. Oken. That's where he is from. So please welcome him for this next talk. Thank you.
How about now? Good. All right. So I know Dr. Zayas ran a little bit over his time. I'm just going to rub that in a little bit. But it's okay if you need to get up and grab some water or coffee or take a break while I'm speaking. That's okay. There are a couple of things about Dr. Zayas, who invited me here, and that I want to share. One thing that's in common, as Dr. Tolson mentioned, we trained together. We did a neurology residency together in New Jersey. And the one difference that we have is, unlike Dr. Zayas, the lack of my hair on my head is voluntary. I want to thank Dr. Tolson, the other Susan, and other organizers, and all of the sponsors for making this possible, and all of you for being here and being eager listeners and eager learners. I think that's very important, because if without you folks, this event wouldn't be happening. There are a few things that I want to impart on you folks after this morning. I'm not sure if we should turn this one off. The first is to understand, what personalized medicine or precision medicine is all about. And I think that's important. It's an important concept that's becoming even more important as we have advancements in technology and medicine. The other thing we want to take away from this talk is an appreciation for the complexity of Parkinson's disease. And this is something that Dr. Zayas and Dr. Tolson alluded to earlier as well, and how the disease is so complex. And I hope that with this talk, and as with the prior talks, you're able to take away from this talk. All of the treatments that we have for Parkinson's at the moment, they're symptomatic treatments. So we'll talk about what are symptomatic treatments and how they differ from what we call disease-modifying treatment. And then we'll talk about which treatments are in the pipeline. So this is the way that medicine has been practiced for a long time. And this is the way that research was conducted for a long time. You would have a population of people, and eventually at some point, those people would develop symptoms, whether it's tremor, whether it's stiffness or slowness, or maybe other conditions like high blood pressure, diabetes, and once they develop those symptoms, they give one medication, a medication that we think might be effective, or we might want to study for that disease population, and we give it to everyone in that category, and what happens is that some people benefit, right? Some people benefit, some people have no effect, and other people worsen within the same cohort of patients. And so that drug would be considered a negative study, would be considered an ineffective medication for that condition. However, it's not a personalized, this is not precision medicine. What is precision medicine is when we take these individuals in a population and we try to figure out who is going to get the disease before they get it. Or as the symptoms are coming on, we try to catch it early on, and we try to stratify the risk and try to follow those patients. When we see the signs or the symptoms, and then we give a medication depending on which symptom or subset of the disease they have. So this is precision medicine, right? You can take all of the patients that are in this room, people with Parkinson's disease in this room, and you can line them up and look at them, and they all look different. And this is something that I'm sure many of you have already observed, is that all of the people with Parkinson's, they look different. They have different symptoms, and then the severity of those symptoms are all different as well. And so is it possible to have a subset within those people who are going to have more tremor and have a medication that is targeting that particular symptom, have more, maybe, let's say, cognitive issues, right? And try to have a treatment that targets that issue, and other symptoms. And so we can take those symptoms and try to target them specifically and develop treatments for them, whether these treatments be disease-modifying treatments or symptomatic treatments. I want to give you an example. So if you look here, this is this is knowledge that we have from genetic testing, from genetic research, is that we've been able to identify genes that are associated with a higher risk of Parkinson's. Okay, that's great, because if we can identify patients, we can test people beforehand, in advance, and know that they're at risk for something, then we can monitor them more closely. The second column is for Parkinson's disease dementia. Now, what you can see is that there's clear differences, right? There are some that increase the risk of Parkinson's, but some, those same genes don't increase the risk of Parkinson's disease dementia early on. So what would you do in this case? If you're testing a medication for cognitive problems, would you want to test it in people who don't have cognitive problems? You wouldn't, right? But in the traditional approach, this is what we had been doing for a long time. So what do we want to see? What we want to see is the right patient getting the right drug at the right dose and at the right time. This is precision medicine summarized. And so if you think about the drug, there are medications, just as I mentioned in this example, that you wouldn't want to test in a population of patients who don't have that symptom, right? And then there are the doses. Dosing is very important. Just as I mentioned that people with Parkinson's are all different, our sensitivities to medication are all different as well. I'm sure you guys have encountered, maybe within your own family or people that you know, there are patients who are incredibly sensitive to medication. In fact, I had this one patient that I treated for Parkinson's disease, who was so sensitive to the carbidopa-levodopa tablet that she had to cut it in half. And she was still very sensitive to the side effects. And then she cut the half in another half. And she could barely tolerate it then. So would you want to give her the same medication, the same dose, to someone as someone who is able to tolerate a higher dose? And also the way we clear medications in our system. And there's actually well-known differences between men and women and the way that we clear medications and toxins from our body. So the right drug at the right dose at the right time. And the previous talks also alluded to the fact that there are many patients who, actually the pathology for Parkinson's disease starts long before the diagnosis of Parkinson's. And in fact, research studies have shown that the delay in the diagnosis of Parkinson's can be as long as 2 to 3 years. 2 to 3 years. And it's not uncommon, and I'm sure my colleagues would agree, that when we diagnose someone for the first time and we say, I think you have Parkinson's, these symptoms are consistent with the diagnosis of Parkinson's, that the patient or the family member would say, this had been going on for the past 2 or 3 years, retrospectively, looking back. So, the right time, think about a fire, think about a little flame. If you sprinkle a few, drops of water on it, you'll put it out. But if that flame grows to a large fire, now those same few drops of water won't do anything to the fire. So if the degenerative process that's happening, the pathology that's happening in the brain, if we can identify it early on, then with the same medications that we're trying to use to modify the disease, would they be more effective? And if they would be, then that's exactly when we want to administer those medications. Everybody clear on precision medicine? Very good. Here is a timeline of Parkinson's disease. Parkinson's disease was first, as alluded to earlier, reported by Dr. Parkinson a long time ago, over 200 years ago. And for a long time since then, there were no major discoveries until about 100 years later when Dr. Frederick Lewy described what we know now as the Lewy bodies. Okay, and those are simply put, there are in aggregates, they're clumps of abnormal protein, alpha-synuclein. So synuclein protein, they kind of aggregate and they form these bodies, and that was a major discovery. And shortly thereafter, well, relatively speaking, there was a discovery of the dopamine deficiency in Parkinson's. And that was a major breakthrough because shortly thereafter, in the late 1950s and early 60s, the dopamine trials were happening. And that's when levodopa was first brought into the market in the 1960s. And so that was a major breakthrough. And since then, we understand also how toxins affect the body, such as the cases that were described in California of those individuals, young individuals, who were taking synthetic heroin, and they developed Parkinson's disease, and we knew that was because of a chemical called MPTP. And then in 1996 was the discovery of the first gene that was known to cause Parkinson's. And this was a major, major discovery. And since then, there has been an explosion, a really large explosion of genetic knowledge, of research, understanding the genes that are affecting Parkinson's, that are causing Parkinson's disease. And this has really, revolutionized our thinking about the disease and the mechanisms of the disease. And that's what I want to show with this cartoon here. You don't need to copy any of this down or anything. It's somewhat of an overwhelming slide. And what I want to show you is that the pathology, as we understand it so far, is still overwhelming to understand. And you don't have to understand all of it. But what I want to show you is that there's an intricate interplay of different factors that are causing the disease. So there are genetic factors that some of us are born with, but they're not enough to give us Parkinson's. And then there are environmental factors that also by themselves are not enough to give us Parkinson's. And then on top of that, there's the factor of aging, which we haven't figured out a solution to, and I'm not sure we will. And all of that put together, takes us and causes Parkinson's disease. But aging by itself, all of the things that happen with aging, there's oxidative stress, there's inflammation in the brain, there's different things happening in the brain, but all of those by themselves are not able to cause Parkinson's. What you need is environmental factors and genetic factors. And so those tip the scales from all that is combination of aging and all of those things, they tip the scale into developing Parkinson's disease. And then you also, if you take into account that the aging, if you look at that red line and how it's kind of the threshold for Parkinson's decreases as you age, right? And so as you're aging, that threshold comes lower and lower, and that underlying risk of that you get from your genes in combination with the environmental factors is coming lower and lower as you're aging, as you're moving to the right on that graph. And then there are the unknown factors. Right? Unknown factors are unknown, right? And just like before we knew about the genes, before we knew about MPTP before the 1980s, we didn't know a lot of these things. And so there are so many factors that we still may not know that might be complicating the picture. And so here's a picture of an iceberg, one that you already saw. This one's nicer than Dr. Zayas's, I must say. And one of my mentors used to say, says, a Parkinson's talk isn't a Parkinson's talk until you show the iceberg. And the iceberg is particularly relevant for Parkinson's. Particularly relevant for Parkinson's. Because there are things that you see and the things that you don't see. And many of those things that you don't see are actually occurring a long time before you see the things that you see. So, for example, here's a graph, and here's the time is on the x-axis, and as you're going along, you're getting more symptoms of Parkinson's. And so I just put a random X there, where you develop these symptoms, motor symptoms, okay? And these motor symptoms are maybe tremor and stiffness or slowness or shuffling or stoop posture. And you know, your doctor or your nurse or someone refers you to a neurologist who's able to make the diagnosis, right? But what you don't know, or you realize afterwards, that a long time before that is when the motor and non-motor symptoms had started. And this is what we call the prodromal phase, So this is basically a phase before the clinical phase. The clinical phase is when you come to medical attention and we are able to diagnose you and treat you and monitor you. And so the prodromal phase is really the phase that we want to, and even before that, right, that we want to be able to diagnose or follow or surveil people at that phase for the development of more of a clinical syndrome and try to intervene as early as possible. So this understanding this is incredibly important. And a lot of the technology and the research that has gone into understanding the genes and the risk factors so far has made this more possible. Although this is not mainstream yet, but I think in the future, I can't say in how many years or decades, but it'll become commonplace to monitor people. Look for these genes, look for, do routine testing for decreased smell sensation, for example, something that we don't routinely do as neurologists, and to look for other symptoms that might suggest the prodromal phase. So knowing all of that, how should we approach research treatments? What should we be doing? And here is a simple cartoon. Don't worry about the nitty-gritty stuff that's in there. But what I want to show you here is that the development of that abnormal protein, the synuclein, it happens in a lot of ways. Okay, so there's first the synthesis, the creation of that alpha-synuclein, and then there is the aggregation of the alpha-synuclein, and then there's also steps that are involved in degrading the alpha-synuclein, and then there are steps that are involved in propagating the alpha-synuclein to other cells. So just like the example of the fire, when you start off with a little flame, the things that are around it are the fire will spread to those areas. And so the same way the degeneration that's happening in the brain is spreading to other parts of the brain as well. So what can we do? What we can do is we can actually target each of these steps, right? We can target each of these steps. And whether we're going to find one drug or multiple drugs, as Dr. Tolleson had alluded to earlier, where he was suggesting that maybe there's going to be more than one drug that's going to be the disease-modifying therapy, right? Maybe it's the step where a synuclein is created, where it's synthesized. Maybe it's the step where it's being degraded. Maybe it's the step where it's being propagated to other parts of the brain. And so there are actually some recent trials that had happened with some immunizations and vaccines as well that I'm going to talk about a little later. But this is, in a very brief, simple diagram, some of the steps that we can take to develop treatments that are going to modify the disease and not just treat the symptoms. So what are those different kinds of treatments? The treatments that we have available now are the symptomatic treatments, right? You have tremor, we give you medication for the tremor. You have urinary symptoms, there are medications for that. You have fatigue, you have depression, anxiety, we treat those symptoms. But it doesn't affect the underlying disease. Disease-modifying treatments, on the other hand, those are treatments that either they could do a few things. They could either bolster, compensatory mechanisms, or they can rescue the cells that are dying, like slow down their dying process, or they can probably restore some of that function and improve the neurons, the number of neurons or the quality of neurons, or something that has to do with the creation of dopamine and to decrease the alpha-synuclein from being synthesized, propagated to other parts of the brain. And so with the next slide, I really mean to overwhelm you, okay? So I'm going to give you about 10 seconds to copy all of this down, and then there will be a quiz afterwards. So why do I show you? So this is one of probably 4 or 5 lists, okay, for all of the treatments that are happening as of end of 2021. So there are probably maybe a few more that were added in 2022. So, and I show you this for a few reasons. Number one, I want to show you that there's a lot of research happening. Okay, because my patients and I'm sure my colleagues would agree. When they come to me, they ask me, is this disease going to be cured in my lifetime? Are we going to modify the disease, slow it down in my lifetime? And a lot of them, a lot of people in general, not just patients, but we're frustrated by our ability to do so many things, send rocket ships to other planets, to send people to space and bring them back alive, to do a lot of things. We have a lot of technology, a lot of advancements that are happening, and yet we can't figure out how to slow down Parkinson's. And hopefully, watching the talks from today, listening today, hopefully gave you that appreciation that this disease is quite complex. There's pathology happening in a lot of different places in the brain. Even at the cellular level, there are many, many areas within the cell that are potentially contributing to the pathology in Parkinson's disease. So, showing you this slide, I'm sort of highlighting, and actually my next slide looks the same, and the next slide looks the same, and the next slide looks the same, okay? So one point obviously to emphasize is that there's a lot of research that's happening. The second is that you'll see in this column that says DMT is disease-modifying treatments. What I'm trying to show you is that there's a lot of research happening to try to modify the disease, and I think that is very promising and very important. And we'll go through this in a little bit. I'll try to put all of this into perspective for you. This is the next slide. Still a lot more disease-modifying treatment. And here you can see that these are treatments that are symptomatic treatments. So we have things being tried for anxiety and for cognition, for memory problems, for constipation, for depression, for gait and balance, for hallucinations, for impulse control disorders, and other symptoms. And so to put this all into perspective, I want you to understand a few things about clinical trials, okay, how research happens. Because when you come to me and ask me, well, when is this cure coming? When is this disease-modifying therapy that I'm reading about in the journal, in some paper, when is this going to be available for me or for my loved one? So phase 1 studies are really, really small studies. So first, medication is tested in a petri dish, in a lab somewhere, and if it seems to be doing what they think it's doing, then they test it in animals. They might test it in mice or other rodents or even monkeys or other animals. And that's all preclinical work. And once there's some indication that those medications might be working in animals, then they bring it to human clinical trials. And that's where, in phase 1 studies, you see a very small, it's a short study, it's usually less than a year, and it's a few patients, 20 to 50 usually, sometimes as many as 100. And basically what we're looking for is that whether this medication, this drug with this compound, is really doing what it was doing in the animal models. Is it treating the symptoms? Are there any major side effects? And so we're looking at the feasibility of that in human beings. In a phase 2 study, which is usually longer, about 2 years, and a lot more patients, up to 200 or 300 patients in a phase 2 study. We're looking at, is the medication effective and is it safe primarily? Is it safe? Are there a lot of side effects? And again, that study might take a couple of years. And then a phase 3 study is usually what's required to go to the FDA for approval. And that's usually a few hundred patients to even as many as 1,000 or 2,000 patients. And that study can take several years. It can take 2 or 3 years. And again, we're looking at, is this medication effective? Is this drug effective? Does it do what it's intended to do? And does it have any major side effects that make it intolerable or that it's really putting other people in harm's way? And so as you look at knowing that knowledge, as you look here on the left, which is a summary of the previous slides, these are all the various agents that are being tested as of just last year. And the top half of the circle are all of the medications that are trying to modify the disease. Okay, and the bottom half are medications that are just treating symptoms symptomatically, just treating the symptoms. And there's a lot of treatments. And so how do we put that into perspective further? Is that if you look at one thing I want to highlight from the box on the left is that if you look at all of the trials, 156 of them, there's a good chunk of them that are disease modifying. Right? There's 65 of them are disease modifying. So a large proportion of what we're doing now in the medical research world for Parkinson's is to modify the disease, which 10, 15 years ago wasn't the case. Okay, so there's a lot of attention going into trying to modify the disease. The other thing that I want to highlight from the box on the right is that if you look at all of the, what kind of drugs are we using? Are we using novel drugs? Are we repurposing medications that have been used for other diseases? Are we bringing back focus on reformulation of the medications that we have already? And interestingly, the vast majority of the 156 drugs that are being tested, the majority of them are novel. So they're completely new mechanisms. And I think that's very, very promising for the field. So that makes me really optimistic. However, if you look at the phases that they're in, if you look at that top where it says novel, if you look at that row, the vast majority of them are in phase 1. Okay? So how long does it take to go from phase 1 to phase 2 to phase 3? So we talked about the duration of those trials. Phase 1 studies usually take about a year, and then it takes usually about another year to do the analysis, to get the publications out, to start designing the next study if it's successful. And so that might take another year, and then the phase 2 study will be another 2 years, followed by another year of analysis, of putting together the next phase of the study, and so the phase 3 study, which might take another 2 to 3 years, and then obviously time after that to analyze the results, and if it's successful, to take it to the FDA. So you can imagine a process that takes well over 5 years, somewhere in the range of closer to 10 years, and maybe even a little longer than that. So when you see things that are in phase 1, that makes me optimistic. makes me hopeful, but you know, I don't want to give false hope because a lot of those medications might not make it to the future stages. Now, just looking at those studies and slightly differently, again, this graph, you don't need to worry about how busy it looks, but I want to point out a few things in all the phase 1 studies that are going on. And many of them are dopaminergic medications, kind of like the dopamine agonists or the medications that affect dopamine. Many of them are microbiome, affecting, as we'll hear in the next talk, things that are affecting the gut and how the bacteria in the gut may be affecting our propensity to get Parkinson's disease and how it spreads to the central nervous system. There are medications that are non-dopaminergic. There are medications that are targeting alpha-synuclein. You can see there's a cell therapy where there are actually infusions, either through the IV or direct implantation into the brain. And again, this is phase 1, right? So it has to pass phase 1 for it to proceed further to the next phases. There are other medications that are being used, being repurposed from other things. So G agonists these are medications that are used to treat diabetes, for example. In fact, if you have relatives who have diabetes, some of them might actually be on these medications. A lot of my patients have asked me if we should just skip the FDA approval and just start taking the medication, since it's available commercially. And we don't have the evidence. In fact, our center at Brown is part of this particular clinical trial and a few others that are looking to modify the disease progression. So there are a lot of different mechanisms in phase 1. And in phase 2, just about the same amount, but you can see that a lot of them have to do with non-dopaminergic medications. And again, there's cell therapy, dopaminergic medications, repurposing of other medications for Parkinson's as well. And lastly, in phase 3 are mostly dopaminergic medications that still are treating the symptoms of Parkinson's disease and not definitively causing any disease-modifying effect. Now, a lot of these therapies might actually be causing disease modification. It's just that when we are doing the studies, it's easier to study it for a symptomatic benefit, look for a symptomatic benefit, and then to see if there is additional disease modification associated with that as well. Those studies, it's just the way the studies are organized and they are approved. Now, I want to focus on 3 clinical trials that happened recently, okay? And then we'll wrap it up. We'll be done shortly. The first of them is kind of an immunization for synuclein. This was published very recently. I'm sure some of you might have seen it in the news. This was published about a month or 2 ago. There are 2 trials. Well, one was primarily an American trial, and one was a European/international trial of 2 different immunizations for alpha-synuclein. And what they did was they give this injection that was supposed to, it's a once-a-month injection, and they were testing 3 different doses, low dose, medium dose, and high dose. And then there was a 4th group that got just the placebo, right? Placebo is just like a water or saline injection. And so what they were trying to look for is if these immunizations can actually start to take that synuclein and decrease the propagation of it. So try to capture it, decreases aggregation and propagation. And so it's kind of like a vaccine that we would get for COVID or something like that, where you're trying to the mechanism may be a little different, but you're trying to capture the bad guys and try to get them cleared out of the system. And after a year of being on this medication or being on the placebo, they looked at the differences between the 2 groups and found that there was no significant difference between people who were on the medication versus the people who were on placebo. And this was the second drug. It was called prasinezumab, and this had very similar findings. The side effect profile was a little bit different. Now, the third medication, however, that I want to talk to you about, this was published in 2020, so it's a couple of years old. And this medication is called isradipine. It's a calcium channel blocker. That's not important for you to know, except that some of you, if you have high blood pressure, you might be on a medication called amlodipine or Norvasc, or you probably know somebody who's on that medication. And this is kind of in the same family of medications, but this gets into the brain a lot more than the medications that we use for blood pressure, okay? And so similarly, this was a phase 2 study where they looked at patients who got the drug versus those who got the placebo. And they gave it to both groups for 3 years, so enough time to look at whether this was modifying the disease. Now, what happened? After 3 years, what they noticed was that there was no significant difference in the motor performance. There was no significant difference in the motor performance. However, there were some researchers, they were just not convinced. They said, yes, there's no difference, but this drug, this medication, and the mechanism is just so promising. And they went back and they looked at the serum, the plasma concentration of the medication, and to see if she takes the drug and I take the drug and he takes the drug, do we all get the same amount of drug in our bloodstream? Because perhaps, I've got different kind of bacteria in my gut, he's got something different, she's got something different, and the absorption of that medication is different in everybody's gut. And so the levels in our bloodstream might actually be different. And in fact, what they found was that they are indeed different. And this is something, as I mentioned before, is a well-known fact that the clearance of medication and the absorption of medication, it differs. And it can differ by racial differences and also by gender differences. So what they found was that people who had more concentration in their bloodstream, their need for levodopa at the end of the trial was lower. So people who had the higher doses in their bloodstream, they actually didn't need the levodopa at the end of the trial. So their chances of requiring levodopa at the end were lower. The other thing is that for those patients who did require levodopa at the end, their doses of levodopa were lower. So why do I show you this? And I show you this because actually the third point they also found was that if you exclude tremor, and tremor is, for those of you who experience tremor, tremor can be tricky to treat sometimes because your other symptoms, your stiffness and slowness and shuffling and other symptoms might actually improve, but tremor doesn't improve as much. And I'm sure many people have experienced that. So tremor is a tricky symptom of Parkinson's that we still need to know more about. But if you exclude the tremor, there was actually an improvement in motor function in patients in participants who were on this research drug. So what does that mean? That means we need the right patients to get the right drug at the right dose and at the right time, right? So, and I show you these, again, there's a lot of time, there's money, effort, your participation that goes into these medications, these clinical trials. But at the end of it, sometimes we learn more from a failure, I put failure in quotations, than we do from a success. Okay? So I hope that these trials that were recently shown to be negative trials, and again, I put that in quotes, we might actually learn a lot more about these medications and who might benefit, and at what doses and at what times. And so I think the field is headed in that direction, and I think the story for these drugs might not completely be over yet. In conclusion, I hope you appreciate that PD is an incredibly complex disease and is very heterogeneous. It's very different from one person to the other. There is a lot of research that's happening already, but a lot more research is needed. A lot more research is needed. There are a few areas, and previous speakers also alluded to this, that I think we need to improve upon. And these are not things that we can do very quickly. But we need to be able to understand the cause and the mechanisms better of Parkinson's still. We know a lot, but we need to learn a lot more. There are more accurate development of animal models. For a long time, we were using animal models that were purely from environmental toxins. And that's not the way that Parkinson's always happens, not because of environmental toxins. So that was perhaps one reason why many of the clinical trials were failing. Identifying better targets and engaging them in a better way, perhaps dose identification, determining appropriate doses of those medications, identifying better biomarkers, right? So if you look at just the better ways of measuring the disease, if your primary doctor gives you medication for diabetes, and every day you're checking your glucose, you know when it goes up, you know when it goes down, because you can measure it so well, right? And we don't have the same kinds of measures for Parkinson's. Because surely we can measure tremor, we can measure stiffness and slowness, but how quickly can we measure them? Not that quickly, right? You have to go to your doctor has to be specialized and trained in Parkinson's, and then they do this examination, and so it doesn't happen very often, and you can't repeat it very quickly. And so we need better measures. We need to be able to measure whether it's a brain scan, whether it's a blood test or some other kind of test. We need to be able to measure those things better. And then initiating the treatment sooner. So when we can identify people who are at risk and try to treat them before their symptoms appear clinically. Lastly, this has to be a collective effort. I'm sure many of you have heard through the Parkinson's Foundation, through the APDA, and others, that a bill was introduced for approval. It's actually, you can see the tracker there is only introduced, so it has to pass the House, pass the Senate, and then go to the President. So there's still a lot of hurdles, but the fact that somebody thought of introducing this bill, I think was a big accomplishment. But we can't stop there. We need your support and everyone else's to make some noise about this. And this is an act that is similar to something that was done for Alzheimer's disease, and the funding for Alzheimer's disease is significantly more for Parkinson's. And so hopefully with something like this, I think there will be a lot more hope and optimism on the horizon. And I thank you for your attention, and I think I made it just in time. So I'm happy to take your questions afterwards. Thank you all. The questions I hope are fairly self-explanatory. The mechanisms underpinning Parkinson's disease are complex, which makes it difficult to develop effective treatments. So if you get that one wrong, this is because you were sleeping during my talk. Non-pharmacologic treatments like exercise and physical therapy are essential tools for the management of Parkinson's disease. And that's everybody knows that to be true. And I think we'll be doing a little bit more of that after the break. Thank you very much.
Thanks, Dr. Akbar, for a great talk. I hope that gave you guys a lot of hope. There's a lot of stuff on those lists that's being looked at. So we are now breaking for lunch. Again, they will bring lunch to your table, but the desserts and the beverages are on the sides here. We'll start again at 12:30. So thank you. Everyone, we're going to get started again. Before I introduce Dr. Barbu for our next talk, I had two pieces of housekeeping. One is, if you guys have questions for us, please write it down on those papers, and we'll have staff coming around to pick those up for the question and answer session at the end. The other thing is, I got asked about how to get these aware and care kits that Dr. Zayas mentioned. You literally can put in Parkinson's Aware and Care Kits in the Google bar. You can also put in Parkinson's Foundation. That'll take you to the Parkinson's Foundation website. So either one of those should work well for you. And I guess the third option is come to our clinic. We have them in our clinic as well. So I'm very privileged to introduce Dr. Barbu. Dr. Barbu is our third and last cold center movement disorder neurologist. She has been with us now for a little over a year. And we're very privileged to have her. I can see some clapping. Yeah. Whenever I have to introduce her, I always say the same thing. My office is right next to her, and everybody comes out smiling, and I'm like, what am I doing wrong? So, but just in way of background for her, she went to the Medical College of Georgia for medical school, which is where I went, so we have that. And then she went out to Phoenix, Arizona, and did her residency there and her fellowship before coming back here to the South. So we're very pleased. She has a lot of similar interests to mine. She's very interested in some of the neuroprotective therapies and early Parkinson's, and also DBS. She's actually the head of our DBS program. So again, please give her a warm welcome.
Okay. Oh, good. My volume is on. Perfect. Okay. I wasn't sure. So I'm going to be talking about the relationship between your gut bacteria, your brain, Parkinson's disease symptoms. Wow, I feel like I'm echoing. Hold on. Is it better? Okay. So these questions you should have, thank you. So these questions you should have, and I'll go over them towards the end. No disclosures. So let's start with a quote. There we go. From Frank C. Church. So live each day. Your disorder does not own you. Make every new day better. Always remember, you are still in charge. Okay. So we're going to be talking about the evidence that has come out showing the relationship between your thank you, that's better. The gut bacteria in your brain and Parkinson's symptoms. We're going to be looking at different areas of the gut, trying to manipulate it and see how we can influence that access. And then towards the kind of second half of the topic, we're going to talk about what you can do about it, lifestyle factors. Okay, introduction first. So the human gut is composed of 100 trillion bacteria. We have a lot. And so during birth, when we are delivered, we are given this bacteria from our mother and from the manner of our birth, C-section, vaginal delivery. And then as we go through the next days of our life, our diet further influences our gut bacteria. And when we get to age 3, we've reached adult complexity. So it happens pretty faster than you think. Okay. So the gut-brain axis, they talk to each other in both directions, and it's composed of many systems. So we got the gastrointestinal tract, I'm going to call it GI for short, the central nervous system, so that's where your brain and your spine is housed. We have the autonomic, the enteric, which is your gut, and we have neuroendocrine and your immune system. So they're all involved in this axis. And they all communicate each other via neurotransmitters and also through neurons. And so there is a particular nerve called the vagus nerve, and it's located like right next to your stomach, and it travels up to your brain, and it's involved in this communication. And I'll tell you more about it later. And then your gut bacteria further regulate this axis, so they're all talking together. Okay. So gut dysbiosis, so that's when the ratio of good and bad bacteria in your gut is off, and it can cause various neurological diseases. So if you look at the table in front of you, certain bacteria are elevated and reduced in stress, depression, autism, Alzheimer's disease, and Parkinson's disease. Pay close attention to enterobacteria and it's elevated in Parkinson's. So I'm going to talk about that a little bit more shortly. There we go. So the gut bacteria composition is different between people who have Parkinson's disease and those that do not. And what happens is when your gut ratio is off, it causes an imbalance in your system and you form inflammation and it causes the walls of your colon to get leaky. So it makes you more susceptible for toxins getting in. Let's see. Okay. So there are certain bacteria in your gut that produce dopamine, and they are so hard to pronounce. Escherichia, Bacillus, Lactococcus, Lactobacillus, and Serratia. Some of this I had to Google pronounce. Yeah. And so what happens is these gut bacteria produce almost half of the dopamine in your system, which is amazing. We can get dopamine from another source. And then enterobacteria, that was the one that I said was elevated in Parkinson's in the other table. That is not a good bacteria to have. That's associated with more severe symptoms in Parkinson's, and it can cause problems with balance and walking. Now, looking at the relationship between this axis and mood. So we know that chronic depression and stress can alter the axis and also the communication between your brain and your hormones. There was a study by Dr. Dodia that showed that stress caused dopamine loss in mouse that had Parkinson's disease. They also looked at rats where they were germ-free, so they made sure there was no bacteria in their system. And they noticed that they had more anxiety-like behaviors, which tells us that gut bacteria influences our mood. And so this tells us maybe if we manipulated our gut bacteria, could we change our mood, like our anxiety and depression in Parkinson's disease? Now, going into the etiology of Parkinson's disease. So we've heard about alpha-synuclein. When alpha-synuclein, so there's normal synuclein in your gut, but when there is inflammation, it causes the alpha-synuclein to misfold, called suclein to misfold to alpha-synuclein and then travel up to your brain. And so we believe that this accumulation starts in the gut and travels up to your brain through that vagus nerve that I was talking about earlier. And how they came about some of these studies is that they had a group of patients who developed Parkinson's disease who had colon biopsies in the past, like 2 to 5 years prior to their first symptom. And when they went back and looked at their biopsies, they found alpha-synuclein in there. So it was present before their first symptom. And if you look at the premorbid symptoms of Parkinson's, the ones that show up before your first motor symptom, like constipation, anxiety, depression, a dream enactment, they in some ways follow the path of the alpha-synuclein from your gut to your brain. So for example, constipation many times is seen 20 years before, so starting in the gut. Then REM behavior disorder, which is that dream enactment, 10 years before, we're traveling up. And then depression, 5 years before, we're already deep in the brain. So in many ways, it follows that progression. So there was a study by Dr. Kesharvazian that hypothesized that the imbalance of gut bacteria in your system could trigger inflammation and cause synuclein to misfold into alpha-synuclein and then start to spread and put you at risk for Parkinson's disease. However, this migration hypothesis is controversial. Some studies were able to show this and others were not. So studies are still ongoing, but more and more evidence is coming out over time. Okay. So we're going to look at if we manipulate certain areas of the gut, can we influence the risk of Parkinson's disease? So one was that vagus nerve that I was talking about. So there's a theory that neurotropic pathogens, these are pathogens that like to attack your nerves, enter the brain via your nasal route and also through your gut via the vagus nerve. So if you look at the picture, what they tried to do was cut the vagus nerve in certain areas and see how much of a cut would alter that pathway. So when they did the highly selective vagotomy, they took out like teeny little nerve branch endings. And then the selective vagotomy, they took out, like it splits, they took out one branch. And then for the truncal vagotomy, they cut the whole thing. And out of all of them, cutting the whole thing actually helped reduce the risk of Parkinson's and slow that spread of this alpha-synuclein up. So that was very interesting. They also looked at appendectomy, so removing your appendix. So the appendix is not as useless as we think. The appendix can regulate bacteria composition, and it contains alpha-synuclein inside of it if you have Parkinson's disease. So they did a study looking at 1.6 million individuals, and they found that those who had an appendectomy got rid of their appendix, the risk of Parkinson's reduced by 19%. And then they went further and looked at people that lived in rural areas and urban areas and tried to see, did the appendectomy have more of a significance depending on where you lived. And what they found was that in the rural areas, it was even a lower risk, a 25% risk. But in the urban areas, no difference. We don't know quite why, but we think there's more pesticides in rural areas, so more exposure and risk for Parkinson's disease. So maybe the higher concentration affected those results, but that's a hypothesis. Now, please do not go and cut your vagus nerve in your appendix. Don't do that. Thank you. Okay, now looking at the relationship between the gut diseases and Parkinson's disease. So you learned earlier about LRRK2, the genetic mutation for Parkinson's, and they found that in 24,500 individuals, LRRK2 was associated independently with Parkinson's disease and Crohn's disease, which is a type of gut disease. And so there's a genetic link there. They also looked at a study to see in Parkinson's disease what was the incidence of different inflammatory bowel diseases like ulcerative colitis and Crohn's disease. And what they did was they found 1,700 individuals. They had to have at least 2 diagnoses for Parkinson's, and they should have filled 1 Parkinson's medication so that they know in that register they truly had Parkinson's. And what they found out was that the incidence of Parkinson's disease among those who had inflammatory bowel disease was 28% higher than those who didn't have like Crohn's disease or ulcerative colitis. So we have a link there between those 2 diseases. H. pylori, so Helicobacter pylori. I'm going to say HP for short. So HP is very common in the world. We know that it can cause stomach ulcers and acid reflux. That's what it's most famously known for. But there's a relationship between HP and Parkinson's as well. So the presence of HP plays a role in how well you absorb your medications. It can hurt the absorption of your medications. And they think it's because the bacteria has negative effects on ghrelin expression. That is a protein in your gut. Its job is to improve how well your gut moves. So like people who have gastroparesis, their gut doesn't move very well, and that happens in Parkinson's as well. And also ghrelin can go to areas that will help promote more dopamine release in your brain. So if HP is affecting this negatively, then it's hurting how well your gut moves and how much dopamine you're able to get. Okay. So not only is HP present in the stomach, it's also present in your duodenum, in the small intestine. And that's an area where levodopa is absorbed. So it's not affecting only your stomach, but it's affecting your duodenum as well. There was one study that showed that patients who had HP infection, they required more levodopa medication compared to those that didn't have the bacteria in their system. There was another study that showed that if you were able to completely treat HP, it improved how well your levodopa kicked in, how much total duration of on time you had, how bad your motor severity was, and it improved your quality of life as well. So HP, we think, uses levodopa to help its own growth, and so gets in the way of how much levodopa is available for you to absorb. So these are 2 studies that I want to put side to side. The one study on the left shows 102 patients with Parkinson's who underwent an HP urea breath test. So that's kind of like a screening test for HP infection. And then they did blinded evaluations of their exam. So they did their Parkinson's motor exam to the UPDRS scale, and you've seen us use this scale when we examine you in clinic a lot. And what they found out was that 33 out of 102 patients were HP positive. And so they did look at their UPDRS and their time tests of motor function that showed that the group that was HP positive had worse total scores compared to those that didn't have it. However, the two groups did not differ in how bad their severity of their symptoms were and how bad their motor fluctuations were. And then the other one showed 80 patients with Parkinson's disease who also had a positive HP Euro test, but they took it one step further. They took half of them and gave them like sugar pills, placebo, and the other half, they gave them the treatment for H. pylori, and it's a triple therapy. So it involves amoxicillin, clarithromycin, and omeprazole. And what they found that at 12 weeks, there was no significant difference in the scores between the ones who had the therapy and the others that didn't. So what does that tell us about HP? What's the future of this bacteria? So we can say that the eradication of HP may be recommended during levodopa treatment of Parkinson's disease, because we want you to be able to absorb the medication better and get more out of it. And also eradicating HP can help your gut function as well. But may right now, because there's still a lot more studies that we need to do. A lot of these studies, as you saw, were small studies, like 102 people. We need to do bigger studies. So antibiotics. So we know that antibiotics can alter your gut bacteria. Hence, a lot of us take probiotics when we're on an antibiotic. And so there's a lot of research coming out that antibiotics, because they change the ratio of the gut bacteria, they can cause inflammation and make the walls of your intestine more leaky. And so things are getting in and out, toxins that you don't want. And then also the synuclein in there can misfold and become alpha-synuclein and spread. So they did a study looking at the impact of antibiotic exposure on the risk of Parkinson's disease. And they had 13,000 Parkinson's cases and 40,000 controls, so people that didn't have Parkinson's disease. And what they found out was that exposure to certain antibiotics, depending on when you took it, certain years later puts you at a higher risk of Parkinson's disease. For example, if you were exposed to anti-anaerobics and tetracyclines 10 to 15 years before, sulfonamides and trimethoprim 1 to 5 years before, and then antifungals 1 to 5 years before were positively associated with the risk of Parkinson's disease. I know. So then they did another study. It was 59,000 people who were women, and they asked about how, like, their total duration of antibiotic use. And what they found was that antibiotic use during the past 4 years was not associated with a future risk of Parkinson's. So we had one study that said it did, another study that said it didn't. But there was a limitation to this study. There was no register that they could look in and see when and what they took things. They had to ask patients to think years back what they took it for, how much, and that causes recall bias. We're not going to remember all of those details. So that was conflicting in this study. So we know that antibiotic risk conclusions from animal and human studies conflict. And the reason behind this is that in human studies, a lot of us, and this was a thought back in the day, that if you didn't get an antibiotic, even if it was a viral infection, I wasn't going to get better, you weren't treating me right. And so we used a lot of antibiotics back then, and we still do. And that can kind of change the results of the research we try to do. And in animal studies, that's not the problem, because we control what they take, what antibiotics they take. So there's a lot of conflicting results. So it tells us we need to do more controlled studies where we try to control for all these factors to find out if antibiotics hurt us or protect us. So stay tuned. Okay, my favorite, lifestyle. Now get your pens and papers out. Start jotting notes. So first, coffee. So we have strong evidence that coffee reduces the risk of Parkinson's disease by 30%. And the theory behind this is that coffee affects your gut bacteria, the ratios, in a good way. And we think maybe that's why it has such promising effects. Also, we found out that coffee can reduce inflammation in your gut, and it can help reduce the misfolding of alpha-synuclein, the propagation through your system. So good benefits there, but don't drink too much coffee because you're going to get more tremors and more jittery, so be careful. Now, neurotoxicity. So these are toxins that want to attack your brain cells, your neurons. So Western-style diet here. So Western-style diet has a lot of processed foods, which increase inflammation in your gut, cause leakiness in your gut, and change your ratio of bacteria for the worse. And we know a lot of our food and water here are the largest contributors of toxin exposures due to consuming unfiltered water, processed foods, sugar substitutes like Splenda, non-organic vegetables, and fruits treated with pesticides and herbicides. And what we know is that toxins are fat soluble, most of them. So the more fat you eat, the more you're able to absorb these toxins and then hurt yourself and increase your risk of Parkinson's. So for every 200 grams per day of milk or 10 grams per day of cheese consumed, the risk increases by 13 to 17%, which is very hard for me because I love cheese. So I've been trying my best to cut it. I'm working on it. And then we know that environmental causes are difficult to confirm in human trials, but a lot of research support that toxins such as pesticides, herbicides, industrial waste, heavy metals play a large role in the risk of Parkinson's and progression of Parkinson's. So you want to try to keep your fat content lower. Don't eat such high fatty food. Okay, to the diets. Next year, I'll make sure we eat a Mediterranean diet. So, out of all the diets that were at, the ones that had the highest evidence for Parkinson's was Mediterranean diet and plant-based diet. So the Mediterranean first. So Mediterranean is heavy into cereals, beans, nuts, vegetables, olive oil, seafood. Not so much red meat and dairy. That's much lower in the diet. So we know that the Mediterranean diet improves gut bacteria and provides more diversity in bacteria in your system. So they had a study. They looked at 41,000 women in Sweden, and they were asked to follow a Mediterranean diet. And how strict they were on this diet was also measured. And what they found was that they followed the women over time, and a median follow-up of 10.9 years, 101 women received a diagnosis of Parkinson's out of the 41,000. And so the women that were more strict with a Mediterranean diet had a lower risk of Parkinson's compared to the ones that really weren't. So Mediterranean diet really makes a difference. Now, olive oil is a component of the Mediterranean diet. So olive oil has phenolic compounds that are anti-inflammatory, antioxidant, neuroprotective, and they help your immune system as well. And so there was a study. Granted, this was a parasite model, but they were looking at roundworms that had Parkinson's disease, and they gave them olive oil. And they found out that the olive oil reduced the accumulation of alpha-synuclein in the roundworm muscle cells and was able to prevent the cells that produce dopamine from breaking down. So it was beneficial. Now there's a drought in Europe, I heard, so there may be a cut in olive oil. We'll see what happens. Now, there was a study that came out a couple years ago looking at, out of all the things that you do in life, which has the most evidence in reducing your risk of dementia, or if you have dementia, at least reducing progression. And these are what they found. So controlling high blood pressure. The goal is for your top number to be less than 130. But this is tricky in Parkinson's because a lot of people eventually get low blood pressure, or they get orthostatic hypotension where their blood pressure drops when they stand up. So if you're so focused on lowering your blood pressure, you might end up hurting yourself and dropping the top number down to the 60s, which then provides poor blood flow to your brain, and that can affect your memory too. So you have to be careful when you're doing the blood pressure thing. Also, wearing hearing aids if you have hearing loss, or if you don't have hearing loss, trying to protect your ears from loud noise. Because we know that people that have hearing loss that don't wear hearing aids have a higher risk of dementia. And we hypothesize it's because you're not able to interact with anyone because you can't hear. So if you're not stimulating your mind, you're hurting your mind. And then quitting smoking. So even though smoking is protective for Parkinson's, not for dementia. And then losing weight if you're in the obese category. So BMI greater than 30. You have to be careful here too, because Parkinson's causes you to lose weight and have poor appetite over time. So if you're so focused on losing weight, you might not be careful and go the other end and then be too skinny, and that can hurt Parkinson's as well. So you have to be careful here. Treating depression. Depression is a modifiable risk factor. Exercise is very important. Now, this particular recommendation is for dementia, not Parkinson's disease. So they recommend moderate to vigorous exercise, so breaking a sweat for a total of 2.5 hours per week. And then controlling and preventing diabetes, socializing with others. Socializing is a great method for your mind because you have to listen to what someone is saying to you, try to process this, and then come back with an answer to spit out. So it's a good exercise on the brain. And with the pandemic, socialization has been cut down a lot, and so a lot of us are just starting to get back into it again. So if you have a hard time finding a place to socialize, support groups is a great way to do that. Also, reducing alcohol intake. So drinking more than 21 units of alcohol weekly increases your risk of dementia. But there's also the opposite. So drinking less than 14 units of red wine only, might reduce your risk of dementia. Check me on this. When I calculated the 14 units, it came out to be like a tablespoon per day. And none of us are going to drink a tablespoon of red wine a day. A glass, yes, a bottle maybe for having a party, but not a tablespoon. So that was a little strange. And then if you're falling, to try to protect your head, easier said than done, but you want to try to prevent concussions and traumatic brain injury, because that can also put you at risk for dementia. Breathing cleaner air, easier said than done as well. I'm trying to reduce your exposure to traffic exhaust, wood fire burning, secondhand smoke as best as you can, but it's hard where we live. And then they also recommended eating the Mediterranean diet, so not just in Parkinson's, but in dementia too, or the Scandinavian diet, which honestly is similar to the Mediterranean diet. Okay. Now to the plant-based diet, the other diet. So plant carbohydrates and fiber have a higher abundance of Prevotella and Paraprevotella. So these are bacteria, good bacteria that you want, compared to a diet that's high in the animal fat and protein, which have more of the Bacteroides. That's the one that I mentioned was elevated in Parkinson's disease. And so fiber-rich diets appear to enhance good bacteria in your system that form short-chain fatty acids. And short-chain fatty acids are a good thing because they're anti-inflammatory. They did a controlled study looking at 10 people who changed their diet and tried to see how fast the composition of bacteria in their diet changed. And what they found out was that within 24 hours of changing their diet, their bacteria started to change. But when they got to the 10 days of the study, even though it changed, it wasn't enough to change overall populations of bacteria. So the key is long-term diet, not short-term. So dietary fiber is a very good energy source for bacteria. They did a study by Dr. DiFilippo looking at fecal microbiome, so bacteria in the fecal, between children from Europe and children from Africa. And children from Africa had more fiber in their diet compared to the European children. And they found that the high fiber diet in the African children led to less inflammation and increased their abundance of diverse bacteria, and that the enterobacteria, the one that's elevated in Parkinson's and you don't want, was significantly reduced in them compared to the European children that had more of the animal-based diet. Okay, so that was diet. Now we're going to go into supplements. There's a lot of supplements out there, and it's hard because a lot of the supplements aren't FDA regulated, and we don't have a lot of research like comparing different products and knowing what's good and what's not good. But out of the ones that they have looked at, the two with the most evidence so far is vitamin D and coenzyme Q10. So there are two forms of vitamin D: ergocalciferol, which is from plants and yeast, and cholecalciferol, which is from animal products like salmon, fish oil. But what they say is that from the vitamin D3 component, most of it comes from sunlight exposure, biosynthesis on your skin, 90%, which is tricky in Parkinson's because we have a higher risk of skin cancer, so you don't want to be sitting in the sun all day either, so you have to be careful. So vitamin D has anti-inflammatory effects, by lowering the biosynthesis of proteins that are very inflammatory and will attack the nerves, like they will attack the protective cover of these nerves and cause them harm. And so in areas of the brain that is responsible for producing dopamine, vitamin D affected it positively in the studies. And so vitamin D deficiency, if diagnosed early and adequately compensated for by diet, sun exposure, supplements, you want to do a variety, don't focus too much on one thing. It may minimize the risk of many diseases, including Parkinson's disease. Okay, so Dr. Hiller looked at how much improvement you could get if you were with Parkinson's and you were taking vitamin D. And he saw an improvement in balance in people who were taking 10,000 IU of vitamin D daily. And so vitamin D research is still conflicting, though. A lot of the studies are small. Some are seeing benefit, others are not. So we need more studies, bigger studies, to know for sure vitamin D is beneficial or not. But so far from what we've had, it's beneficial and does provide some benefit in Parkinson's. Coenzyme Q10. Oh, my slides are, whoa. Hold on. Oh, thank you, that's why. Thanks for catching that. That's what happened. I'm like, wow. Okay, there we go. All right, coenzyme Q10. So people who have Parkinson's disease have CoQ10 deficiency, but we don't know quite why. And CoQ10 is important because it helps detoxify your body. It helps reduce the toxic burden in your system. And so there were several high-quality studies that showed if you supplemented 100 to 12 milligrams of CoQ10 daily, but more towards the higher side, it helped reduce inflammation in your system and may improve motor symptoms of Parkinson's disease. Now to exercise. I know we're trying to be good and not talk. We talked so much about exercise last year, but it has a lot of benefits. So we know that exercise, the more you do it, the benefit is favorable in changing the diversity of bacteria in your gut. And so they found out that if you exercise, it changed the ratio and diversity of bacteria regardless of what your diet was, which was nice. So this is a benefit from exercise, another reason to exercise. Now to probiotics, popular topic. So probiotics balance your intestinal bacteria and reduce systemic oxidative stress. And so probiotics, a lot of the probiotics on the shelves have lactobacillus in it, which is good. That's what we want, lactobacillus, and it helps produce dopamine as well. But the issue is a lot of the studies showed favor on probiotics that had a multitude of different kinds of bacteria in it. And a lot of the probiotics on the shelf just have one or two. And most of them are lactobacilli inside of them. So it's hard to find a good one. So I always say look behind the bottle and look for like multitude of different kinds of bacteria so you know you're having a variety in that probiotic. So what they show that the frequency of bowel movements increase in patients with Parkinson's who drink fermented milk because it has probiotics in it. And there was another study that looked at a probiotic that was multi-strain, so multiple different bacteria, in patients who had Parkinson's disease, 72 patients. And what they found was that spontaneous bowel movement increased by 1 extra per week. And their stool consistency got a lot better, and so did their quality of life. Okay. So these are looking at different strains of bacteria and what benefit they derive, and you may see this in the back of bottles. So for example, probiotic L. helveticus helps, and along with longum, help improve anxiety and depression because they reduce cortisol levels in your system. Probiotic lactobacillus also improve mood scores with anxiety and depression compared to people that weren't on it. And then probiotic lactobacillus farcimensis help prevent leakiness in your gut, so create a firmer wall so that toxins couldn't so easily get in. And it also help reverse stress on the relationship between your brain and your hormones. And then in animal studies, probiotics containing lactobacilli and bifidobacteria alleviated visceral pain. So that is more like stomach pain, bloating, by reducing the stress and by helping with irritable bowel syndrome, which I know some of us have. I have it, so I take probiotics. Okay. And then probiotic administration for 16 weeks. Some of the studies showed could reduce dyskinesia, so those involuntary movements in Parkinson's, and improve balance and motor coordination. But it was in mouse models that they did this. There was another study in humans that was randomized, double-blind, placebo-controlled trial of 60 people. So even though they did all the right things, the population was small in Parkinson's that revealed that probiotic treatment for 12 weeks reduced the motor scores in Parkinson's. And UPDRS is that motor score that we use. And then probiotics hold potential benefit with improving both motor, so like balance, walking, and non-motor, so mood, sleep, constipation, and Parkinson's disease. And so we are trying to do more studies now to see if maybe probiotics have some form of neuroprotective effect for Parkinson's and maybe could reduce progression or reduce the risk of developing Parkinson's in the future. But the studies are ongoing. Okay, now to prebiotics, which are different than probiotics. So prebiotics are indigestible food fibers, so like soybeans, raw oats, wheat, and barley. And I have a list here of other prebiotics. But the goal of prebiotics is to stimulate the growth and activity of bacteria in your gut. It's more geared towards the good bacteria. And then prebiotics have beneficial effects on Parkinson's by promoting better gut movement inside your system, improving your immune system, and relieving constipation. But a lot of the studies are small, so we need larger studies. So we're seeing a lot of benefit from these studies. We just need bigger trials. Okay. So take-home points. Do not cut your vagus nerve or your appendix. What I'm going to recommend is eat a plant-based or Mediterranean diet, take probiotics or prebiotics, vitamin D and CoQ10 supplementation, exercise, drink coffee, but not too much coffee. And then if you have H. pylori infection, speak to your gastroenterologist and see if there's a treatment to help try to get rid of the bacteria and improve your motor scores and your absorption of carbidopa, levodopa. But the idea behind all of this is we're trying to give more power back into our hands, things that we have control over and that we can do to improve our symptoms. And maybe if the studies are promising, maybe slow down the progression of Parkinson's disease. So that's the goal behind all these recommendations. So to the questions. So which modifiable risk factor reduces your risk of dementia? And so the answer, wearing hearing aids if you have hearing loss. That did not. There we go. Okay. True or false? Probiotics balance the intestinal microflora, so your gut bacteria, and reduce systemic oxidative stress. And so the answer, true. There you go. There you go. Thank you.
We are actually a little ahead of schedule, so if you guys need bathroom breaks or anything, we'll restart at 1:15. But thank you, Dr. Barbu, for a fantastic talk. I will just say on my own clinic, I mean, I get a lot of questions about diet and things like that too, and I wholeheartedly agree with a lot of the things that Dr. Barbu put out there, but sometimes it can be stressful for patients, and I just would encourage you to try and be healthy. There's a lot of conflicting evidence out there, and you're not going to be perfect. You do the best you can, right? So. Great. All right. Thank goodness. Because I don't have a good voice. Whitney Sharp is the physical therapist that currently works in the Cole Center. She's there a half a day a week to help our Parkinson's patients. She also does our DBS preoperative assessments, so we've been really privileged to have her. She's been great for our patients. Just to go through her background, which I know you guys can read, but she's been doing this for a long time. She's been doing neurological physical therapy for more than 30 years, particularly with vestibular rehab and balance. She's working at our balance center at UT. In terms of her degrees, she went to Carson Newman and then got her physical therapy degree from the University of Louisville. I don't know if she'll hurt you as much as Zach, but we'll see.
Is that a challenge? I don't know. So glad to be here with you guys today. It's a privilege to work with these wonderful professionals. They are terrific, are they not? Knoxville's so lucky to have them. So UT Medical Center is really trying to aspire to their level of excellence with what we are offering for our rehab clinics. So in all of our rehab outpatient facilities, we have someone who is LSVT Big certified, except for one. And so most of our clinics, you can go to the clinic and do the LSVT Big program and go through that with us. So how many of you all are currently exercising? Raise your hand. So I don't think you can say too much about exercise because it's so important. Who said, you think you can talk about it too much? But exercise really is medicine, and not only for your body, but for your mind. And that's definitely been proven with dementia and with the decreasing the progression of Parkinson's disease. So it's super, super important. And it's really important to find something you love to do. That's the thing that's important. And we try to get people started on the right path with a exercise program that you start now and keep on forever. And then sometimes you need a little changes with functional. You have run into some problems with function, and so we can help you with those problems too. So maybe every year or two you need to come back in and get a bit of a refresher if there's a problem that you're having functionally, and we can help you with that too. Love that you all are knowledgeable about exercise and involved in doing things that you love. So we're going to do some exercises today. We're going to start out in sitting since everybody's sitting already. So hopefully you can hear me. If you don't, I guess I could pick up that microphone. So we're going to start out in sitting. So let your feet be apart and sit up very tall in your chair. Lift your chest up. Find your very best posture right here because posture is so very important. So we're going to start out with some deep breaths. So you're going to bring your arms down, round your back, exhale, and then inhale all the way up. Take a deep belly breath. Any cracks going on there? I felt a little cracking. And then come all the way down. As you exhale, come all the way down. We're going to inhale up. Our bellies rise as we lift, opening up our chest, and then all the way back down. Exhale as you come down. Let's do one more of these. Inhale all the way up deeply through your belly. I wish I had a picture of you all here. And bring it all the way down. All right, now I want you to scoot to the edge of your chair. And you're going to straighten one leg ahead of you. We're going to do a little hamstring stretch right here. So you're going to sit up very tall. And you're going to lead with your chest. Your back is going to stay very straight. And you're going to come gently forward. We're going to hold the stretch right here. So the exercises should not be painful. We just want gentle stretching. If it hurts you, if you don't feel comfortable with it, you can just watch the rest of us. But your hamstrings are very important because they connect to your lumbar spine and your hips and your knees. So a good slow, sustained stretch is very important. Speak a little louder. Louder. Okay. I'll try. When I'm stretching, my voice goes down. All right, let's change to the other side. I wonder if I can pick up that microphone. Oh, yes, I can. Okay. So let's do the other side. Yay, thank you for letting me know you couldn't hear well. Let's try the other side. So you're going to stay up very tall, lift your chest, and hinge forward from your hips. So you shouldn't feel the stretch in your back. You should feel it in the muscle belly. And you shouldn't say, ah! It should just be a gentle stretch, keeping your chest lifted. Now, as we're stretching, let's talk a little bit about activity versus exercise. So it's really important that you get vigorous exercise with Parkinson's. So where our goal is to get our heart rate up and really exercise a bit vigorously. It's different from just being active all day. You know, some people say, yeah, I'm busy, I'm working in my yard and I'm doing laundry, and that's great. But find time for the vigorous exercise as well. All right, now come all the way back up. Now I wonder how I'm going to do the exercises holding onto this microphone. I'm going to figure it out. I can be resourceful. All right, let's do some shoulder rolls right here. Stay up with your big posture here, trying to keep always your ears over your shoulders, over your hips. So this is the real challenge, to keep our chest lifted. So we're going to do some shoulder rolls, one side and then the other. And when you bring it back, really squeeze your shoulder blades together. Really focus on the bringing it back part, because that's what's really hard. That's what you really need to work on. Gravity wants to pull us forward, right, Dr. Barbu? This is what you need. Really pulling it back. That's it. Loosening up those shoulders. Okay, very nice. Now, we're going to do some weight shifts here. So we're still sitting up very tall. Our feet are wide. Our knees are out. We're going to reach up with one arm. We're going to open up that arm. Maybe try bringing that arm behind your shoulders just a bit. And I want to see if you can peek up at your hand. So you're twisting your torso as you reach up. Now try to flip your forearm back and forth. Just flip it side to side as you're stretching out your torso. Flipping back and forth. Don't forget to breathe. And then come all the way down. Good. Sit nice and tall to reset. And yep, we're going on the other side. Reach it up. Really reach up. Try to get that arm behind your shoulder just a little. Can you flip that hand back and forth? This is a great thing to practice to control your tremors. When we're moving, when we're active, sometimes it helps to decrease that tremor activity. Breathing deeply as you're here. And come on down. We're going to go on the other side once again, reaching all the way up. This time I want you to flick your fingers. And maybe peek up at your hand if you want to. You feel a nice stretch through your torso on that one side? I do. Thank you. Very nice. Now let's do the same thing on the other side. Reach it way up. Flick those fingers up. Opening them up. This is a good trick to use when you're having trouble with dexterity, trying to write your name or button buttons. Those finger flicks really can come in handy. Very nice. Do you see that one side might be a little tighter than the other? I can feel that. Can you tell? All right, now I want you to bring both arms out to the side like this. Sit up very tall. And bring one side to the other. Are you going to be my assistant? Okay. I want you to try to straighten your elbows and reach behind you a little bit more. Again, if this hurts your back, don't force it. And if you kind of twist that leg, that helps a little bit. You want to come up here with me?
I mean, it's good for me, though. I'm stretching.
So straightening your elbows, trying to reach a little further behind you. You are so handy. Thank you so much. Now I want you to open back up. Lift your chest, sit really tall. Take a nice deep breath right here. And exhale. Now we're going to the other side. You ready? Here we go. All the way to the other side. Reaching behind you, letting that foot twist a bit. Letting your elbows be straight. Could you reach with the top arm forward. Let those fingers reach over the other hand just a bit. Really getting that nice rotation through here. Isn't that lovely? I hate that you're missing the stretching because I know, it was so nice earlier. You should see it. Now open all the way up again. Take a deep breath. Really opening your chest. Great. Let's go back to the other side. Here we go. Keep those elbows straight and reach with that top arm over the other. That's very nice. And then open all the way up. Open your chest. Let's go back to the left again. Reaching around. Doing so good. Stretching, stretching, stretching. The holding stretches are more effective. Now open all the way up. All right, now we're going to do a little work on sit to stand. So make sure you've got some space in front of you. So maybe scoot your chair away from the table if you can, so you have a little space to really shift forward. So when we're coming up to stand, we want to really shift forward. Get your arms forward and get your shoulders forward and come on up to stand. So I'm opening up my chest, but I want to keep my belly button pulled in. So I'm going to activate those abdominals. So my abdominals are tight, so I'm not overextending my back, but my shoulders are nice and open. You all look great. Now let's try again. I want you to sit back down, reach way forward. Really get your shoulders over your toes and come on back down. And if you need to use your hands, that's fine too. Just make sure you're really coming forward as you come up. All right, you ready? Let's try it again. Coming forward, standing all the way up, opening up your arms. Belly button is pulled toward your spine. Don't hit anybody. We don't want any accidents going on over there. See, exercise is fun. All right, very nice. Now, we're going to try a little mountain pose right here. So I told you we're going to do a little yoga. This is what we need to do. All right, so we're going to try a mountain pose. I want you to stand very tall, and I want you to reach down to the floor with your little finger. Reach down for your heels. So we're making sure our ears or our shoulders over our hips as well as we can. When we reach back with our little finger, we're really depressing those shoulders and getting our postural alignment just like it should be. You all look terrific. All right, now I want you to open up your arms, reach up to the ceiling. Again, keep your belly button pulled into your spine. Open up your chest, reaching with those arms. Breathing deeply right here through your belly. Now bring the arms back behind you. Opening up your chest. Pulling the arms back to open everything up. We're combating that flex posture. We're getting good extension, but we're protecting our back by keeping our abdominals pulled in. Belly button to spine. Let's do one more time. I want you to inhale as you come up. Inhale. And exhale all the way down. You're doing a great job. She's multi-talented. She's a great speaker, and then this. I'm amazed. All right. Dr. Tollison, is my time over? Okay. Oh, we could have done so much more, but anyway.
My hand was getting tired.
Thanks, Whitney. I heard a little bit. Yeah. Our last speaker is our second keynote speaker. This is Jimmy Choi. This is a real treat and a little bit of a departure from what we usually do. We've mostly had medical professionals up here. Try and get this out. Jimmy is a Parkinson's advocate, and he actually does have Parkinson's disease. He was diagnosed with Parkinson's, I believe, at 27. And just like all of us, when he got something difficult in his life, he struggled for a while, but he he is just an inspiration for those with Parkinson's and without. He's just done incredible things since he joined Team Fox, I think in 2012 is what I remember from the sheet. Yeah, you should read his bio. It's pretty incredible, and really got into exercise. He's run marathons. I've watched the show a bunch. So he has done American Ninja Warrior now 5 times. And I have to keep going back to this bio because it's incredible, but he also has 2 world records. In 2020, he smashed the Guinness World Record for the most chest-to-ground burpees, which we were talking a while ago, everyone hates, and I'm one of them. And then he tied the record for the most side jump push-ups in 1 minute. So pretty incredible. I hope this inspires you. I know we've been hitting on the exercise, but he's an example of what you can do with exercise. The stuff he's doing, I can't do. I mean, this is an inspiration, again, for those who do and don't have Parkinson's disease. So we're very pleased that he was able to come down here and talk to you guys. So with that, I'm supposed to start a video here. Hopefully it's queued up.
Just like everything in the 70s, I was made in Taiwan. My family immigrated to the United States when I was 10 years old. We moved to Bolingbrook, Illinois. I was very active in high school. I played multiple sports. I played baseball, I wrestled, and I was captain of the football team. I met Shiro in high school, and we got married in the year 2000. We have 2 kids, Mason and Karina. Life for us was just beginning. I mean, we had very ambitious career goals. I was very active, played a lot of golf. Really, we were just getting into the groove of being adults. And then I was diagnosed with young onset Parkinson's at the age of 27. Four times what is 28?
7.
That's right. There you go. Nice. Mason, his smile can brighten up any room. Now, Karina, she's a chip off the old block. She loves obstacle course racing, and for fun, we watch American Ninja Warrior. Karina really got into the show, and every time the show comes on, she would say, "Dad, you should really try out. You should try to get on the show." I applied to make Karina happy. American Ninja Warrior actually called me, and they told me, "Hey, guess what? You've been selected to be a participant."
Jimmy Choi. He's a 41-year-old rookie who's also back.
Being on American Ninja Warrior is the most terrifying thing I've ever done, but it proved that I can follow my dreams and nothing can stop me.
Jimmy's story is an extreme example of the way the community is galvanized. Literally, everyone can't do what he did. I can't do it. But one reasonable answer to it is to get engaged in the community, get engaged in the fight, get engaged in research, get engaged in clinical trials. It's part of a call to involvement, and involvement has its own rewards.
I've learned there are positives and negatives to Parkinson's. People have said to me all the time, "Hey, Jimmy, you ran a marathon in 3 hours and 40 minutes. Can you imagine how fast you'd be without Parkinson's?" And I said, "I don't think I'd be running a marathon if I didn't have Parkinson's."
Can keep my hands on myself. Pick out dust the most, put 'em back up on the shelf. Yes, my little baby girl is in need. Am I coming out of left field? Ooh, I'm a rebel just for kicks. I've been feeling it since 1966. Might be over now, don't feel it slip.
From Bolingbrook, Illinois, this is Jimmy Choi. He's running tonight for Team Fox. There's his wife and daughter, Karina, who got Jimmy to come out for this. You can see the trimmers in those hands. There he goes. Come on, Jimmy Choi. Woo! Nice grab.
I've been feeling it since 1966. Now you had your fill, feel it still. We could fight a war for peace.
Boy, it would be great for him to get a buzzer.
Sideways is so technically challenging.
This is it, and you can see he's leading with that right hand to get on the other side.
You can see the power. Oh my goodness, with one hand!
That was a nice one-handed save. But look at Jimmy right here, nice.
Such good
How
form.
great will this be? I want to see Jimmy Choi hit that buzzer.
It would be a moment of a lifetime for Jimmy. Going for that dismount.
We've not seen him on a warp wall.
We can see him hit the warp wall.
You got this, Jimmy. Hit that buzzer. This is it. This is history. This is it. Yeah! If you're struggling with Parkinson, you gotta be inspired. Yeah! You get your moment. You get your moment.
All right, thank you, everybody. Thank you. Scoot this over, make sure it doesn't fall off the sides. How are you guys doing this afternoon? All right. You know, I always get the after lunch crowd, so I know you guys are full bellies, full of pasta. I'm gonna do my best not to put you guys to sleep. But I tell you what, I wanna first of all thank UT Medical for having me here today. I wanna thank, of course, all the sponsors, and of course you guys for being out here, sitting out here and during the long day. Hopefully you guys are learning a lot. One of the things that you guys heard over and over today is exercise, exercise, exercise. Unfortunately for you guys, I'm no different than that message because that's all I'm going to talk about up here. Well, mostly. But I tell you what, I'm so happy to be here because we're back in person. Last year, this event was virtual, right? The events I've been doing for the last 2 years have all been virtual. I mean, it's a crazy time that we live in. In the last 2 years and 2.5 years, we were all forced to meet virtually. And, you know, I almost forgot how to present in front of real live people. In fact, when I was getting ready to come out this morning, I was getting ready to walk out, and I'm thinking, wait a minute, do I have pants on? I'm so used to presenting right in front of a computer just like everybody else, right? But, you know, I still get nervous coming up here, and nobody can tell because they don't know whether or not I'm nervous or I had the tremors. But, you know, my wife always looks at me and she says, okay, Jimmy, just stay calm, right? Just go up there, don't be funny, don't crack jokes, don't try to sound smart. Go up there, just be yourself, basically, is what she's saying. And she says, if you really have to make jokes, make sure that Will Smith is not in the room. So, now, once again, everybody, my name is Jimmy Choi. I am 47 years old. I was diagnosed with young onset Parkinson's 20 years ago, at the age of 27. Now, the first question you usually get is, how did you get diagnosed at such a young age? Well, it was actually an insurance physical that started my diagnosis process. My dad has always said to me, Jimmy, when you get married, when you start a family, you need to go buy life insurance. And I did. So when they sent a nurse to my house to do a life insurance exam, she did a couple of physical examinations, and then all of a sudden she stopped what she was doing, and she goes, Jimmy, can you get up and walk to the end of the room and back? And I was like, that's strange. Sure, why not? So I did, and then she came back, and she never said anything about Parkinson's. She never said anything about anything else. She says, Jimmy, we had a quick discussion about movement, and she asked me certain questions. She goes, I really want you to talk to your general practitioner about what we talked about today, okay? I can't tell you what I think. All I can tell you is that I do insurance physicals on the side, but in my everyday full-time job, I am a nurse in a neurology office. And that's all she said to me, and that started my road to have a discussion with my physician. Now, only 27 years old at the time. I was married. I thought I had it all. I would play golf, travel, start a family, right? Have a boy and a girl, beautiful boy and a girl, my lovely wife, Cheryl, who's standing over there, by the way. Everybody say hi. You know, the small changes that I was feeling in everyday life, I could attribute it to just being a 27-year-old, right? Stress on the job was causing these little twitches here and there. Stiffness, yeah, sure, I wake up stiff and it's hard for me to move sometimes, but I played a lot of golf and I would walk So walking 18 holes of golf, it's like 7 or 8 miles. You're gonna be stiff, you're gonna get sore, right? So everything that I was feeling that was changing in my body, I attributed to just everyday life. So I finally went to my doctors, and after months and months of visits to specialists, to neurologists, I was finally told that it's doing all these different tests, right, that I can only describe as sobriety-like, let's be honest, okay? I was sitting in disbelief in my neurologist's office when I was finally told that, Jimmy, you have Parkinson's, right? It was a clinical diagnosis, which means my doctor's suspicion was based on observation. And it was finally confirmed with 2 things. Number 1 was medication. She gave me medication to take. She said, if you feel better, if most of your symptoms go away, you probably have Parkinson's. And then the second thing was over the next period of about a year, I had two separate DAT scans done, where they actually finally did show that there were actual changes in my brain that confirmed the diagnosis. Now, up to this point, right, I was sure, at the point of my diagnosis, I was sure there was nothing wrong with me. I didn't even tell anybody once I was diagnosed. I didn't tell my parents, I didn't tell my brothers, I didn't even tell my wife. It was only after I decided that I wanted to start taking medication that I did tell her, and that was 3 months later. Now, medication allowed me to live normal, as usual, for now. But what it did is that it also allowed me to ignore my progression. I did absolutely nothing. I didn't even open the pamphlet that I was given when I was diagnosed, okay? So for the next 8 years, I lived life as if nothing has changed. I wanted to make as much money as I can so that I can take care of my family in the future, and I just worked and worked and worked. My wife and I didn't talk about Parkinson's. We didn't learn about it. We didn't do anything, and I just let the disease run its course for me over the next 8 years. Now, as my symptoms started to progress, one by one, they became harder and harder to hide, right? And it's gotten to the point where they were getting really hard to hide from my coworkers, my family, my friends. Now, it felt like I was carrying this burden with me all the time, okay? In fact, I brought my symptoms here today to show you guys. All right, what do we have here? So remember, I was diagnosed, and I was displaying, my toes are okay. I was displaying classic symptoms of Parkinson's, like loss of balance. By the way, if you guys are counting and doing some math, these are 10-pound weights. Each one of these are 10-pound weights. So I was experiencing loss of balance. I was experiencing slowness in my movement, bradykinesia. What else do I have in here? I was experiencing dystonia. For those of you who have experienced dystonia, it's not a fun thing. For those of you who do not have Parkinson's, imagine a Charlie horse that lasts for about an hour. What else do I have in here? Let's see. Of course, tremors, the classic, right? Can you imagine if I was Santa Claus at a Christmas party? This is terrible. This symptom is really, really crappy. Constipation, that's right. Poop jokes always work, no matter how old we get. Rigidity is another. Let's see, what else do we have in here? I'm not done yet. Insomnia, difficulty with sleeping, which is a problem I still have today, but I've learned different ways of handling that. Posture issues, constantly always thinking about where my posture is. What else do we have here? We've got loss of cognitive function, just really having difficulty to think. And finally, this is my favorite, it's dyskinesia. It's not even a symptom of Parkinson's, right? Many of us know that this is a side effect of the medication that we take. So we've got to choose, do we want to tremor about uncontrollably, or do we want to sway about uncontrollably? Take your pick. So as you can see, carrying around all this burden right? I wanted to put this into perspective for you guys, because carrying around this burden, I want you to know that as you interact with people, around you, everybody, every one of us in this room, Parkinson's or not, we are all carrying our version of this backpack. We're all carrying our version of this burden, okay? So at this point, 8 years after my diagnosis, I was 35 years old, and I was unable to hide all of these symptoms: tremors, loss of balance, etc. Okay? I was unable to focus clearly at work. I was unable to smile due to masking. And worst of all, guys, I had 2 young kids, and I was not able to play with them when I really wanted to. This has gotten to the point where I became so inactive that I weighed 250 pounds, and I couldn't walk without the use of a cane. And I was frustrated with set in at that point, just because of everything that was going around, and I would end up snapping at my family for no reason, yelling, snapping at family. Imagine this little 2-year-old girl, I'm standing over her, just screaming, right? I knew I was doing it, and I want to stop myself, but I can't. Okay? That frustration led to depression and anger. And I knew at that point, to be honest with you guys, that wasn't the life that I intended to lead when I got married and tried and was sweetheart. Deep down inside, that wasn't the one I wanted to live at all, to be honest with you guys. Now, if that wasn't bad enough, I hit my rock bottom. 2010, I was walking downstairs with my then 10 months boy, and something. You know what? I figured I got my boy in one hand, and I didn't got a railing. I didn't need my cane, so I went down the stairs, and suddenly I lost. The 2 of us went tumbling down an entire flight of stairs, 10 steps. Now, thankfully, I was able to hold Mason above my body the entire way down, and he was okay, and I took the brunt of the fall. But physically, I was okay, but mentally, I was never going to be the same. I knew then that I had to make a change. I knew I couldn't change the fact that I had Parkinson's, especially when I landed at the bottom. I looked up and I saw that my daughter and my wife had witnessed the fall. The look on their faces triggered something in me. The look on their faces was enough. They're scared. The way that they were scared was enough to scare me to make a change. Couldn't change the fact that I had Parkinson's, but I can change the way that I live with it. So what did I do? I started to educate myself. Finally learning this thing called Parkinson's. Remember that pamphlet I put away 8 years ago? Well, let's open it up. Let's read it. Let's find out what's going on. The more I learned, the more in control I felt. And although when I started to learn more and more, there was an onslaught of information coming in, okay? And I'll tell you what, there's some consistent information there. Number 1, exercise, okay? We know today exercise is the only treatment proven to have slow progression of Parkinson's, okay? Number 2, I am not alone, okay? It took me 8 years to learn that I am not alone. I don't have to do all of this by myself, okay? My friends and family were apprehensive with me talking about Parkinson's because I was apprehensive. Talking about it made it less scary to the people around you and to myself, right? And then I also found that there are others out there who are living with the disease longer than I have, who have done it, who are doing things that are helping themselves. And these are things that I can learn and see if those things can help me in the way I manage Parkinson's. Now, I knew I wasn't smart enough to find a cure for myself, right? I certainly know that I am not rich enough to fund the cure for myself. So I asked myself, what am I going to do? Well, the next best thing I can do is to give my body up for science and participate in these clinical trials, okay? Dr. Akbar talked about all these clinical trials. He put them all up here for you guys, right? And he showed you that stage 1, okay, of clinical trial is about a year. Stage 2, 2 years. Stage 3, 3 or more years, right? But what is not seen on that slide is even before that 1-year clock can start in stage 1, even before those 2 years clocks can start in stage 2, they have to make sure they get enough participants into those trials. What happens in that stage 1 year if it takes them a year to find enough participants? Now it's a 2-year stage 1. So it is up to us to do our part. And that's exactly what I felt that I can do. So and getting involved in all these clinical trials, all this information really just started flooding in. So what did I do? I started exercising on my own, okay? I joined a clinical trial that involved forced exercise. And that forced exercise is basically me sitting in a chair, they hooked me up to a machine, and the machine went, making me go along with it, okay? But I realized after a few sessions that I would feel better after these sessions. So I started doing a little bit more on my own. I went home, I walked with my family, I walked to the mailbox and back. That's great. Tomorrow I'm gonna go a little further. I went down to the block and back. If I felt good, I'd leave my cane at home and I just kept going. Changed the way that I ate, the weight started coming off, a block became 2, 2 blocks became 3, and then I started jogging. And then I started running. And then one day, while on a business trip, I sat down in front of in the airplane, right there in the seat back pocket, there's a Runner's World magazine. And I pulled out Runner's World magazine. There was a gentleman in there, and he has Parkinson's, and he was running a marathon. And that inspired me to sort of push that envelope to the next level, okay? Now, remember, I was on a business trip. Why was that magazine there? No idea, but it was there. So I decided I'm gonna start slow and work my way up. So by April of 2012, okay, so 2012, April, I decided that I was going to run my first 5K. And I did. I trained every day a little bit more. I asked myself this question: what am I going to do today that is more than yesterday? Okay? My training got up to a mile. Mile went to a mile and a half went to 2, etc. I ran my first 5K in April. And I tell you what, from April to May, I ran my first 10K. To June, I ran my first 15K. By September, I ran my first half marathon, which is 21K. And as soon as I crossed the finish line, I knew I was going to do it, and I was going to go and run the Chicago Marathon in 2012. But I was still new to running. Who knew that 40,000, check this out, this is crazy. If you guys aren't into running, this will blow your mind. 40,000 people signed up to run 26.2 miles. And they paid money for that. That's crazy. So when I tried to sign up, they said, Jimmy, we're sold out. What do you mean you're sold out? I can't get in to run in my own city, right? No, you can't. So there was no way in. I was really disappointed. But you know what? Hope is not lost, because you know what? I'm going to start running, and I'm going to try to raise money for charity, okay? So that's where I found the Michael J. Fox Foundation for the first time in 2012. I called them and I said, hey, I know we're only a month away from the race, and everywhere it's sold out. People don't have any bibs, which is entries to the race. Would you happen to have one? They said, Jimmy, we've got one left. And I thought, you know what? Wow, to this day, I felt that that bib was there and it was meant for me. But they said, you can have this bib, but you have to help us raise money. I said, okay, what do you want me to do? He says, you got to raise $2,000 by next month. Remember, I had 4 weeks, 5 weeks, 4.5, 5 weeks to do this. So what do you guys do when you need to raise money? You go to your friends and family, right? For the first time in my life, I had to go and tell my story to my friends and family. I have Parkinson's disease. I am exercising. This is why I'm doing it, okay? I had to reach out, and I started opening up. Okay, it's what you do when you fundraise. But I tell you what, the problem is that nobody, you know, and when it comes to friends and family, nobody really wants to be the first to talk about Parkinson's, right? I'm going to set the scene for you. Many of you know the scene. I'm sure of it. At any family gatherings, you go in family back gatherings, and you go, hey, how's it going? And they know something is wrong, but nobody wants to talk about it. So they're like, how's it going? And then here I am. Do you really want to hear how it's going, or no, I'm going to spare it. So, oh, I'm good. And then you stare at each other for the next 15 seconds in awkward silence. And then you turn away and you go both your separate ways, right? You can see how over time, over many of these gatherings, you can start becoming isolated from your family and your friends. So I started to reach out to them. I started to tell them more and more about what I'm doing, okay? I'm bringing them into the conversation. So I'm removing the elephant in the room so that when I see them next time, they genuinely want to know, hey, how's the exercise doing? Last time you were, you look good. Last time you were fumbling about, now you look stronger. Was that exercise? Was that medication? What are you doing? So now we're becoming interested. We're having that discussion in the family. We're removing that awkwardness. I'm becoming closer to my friends. I'm becoming closer to my friends and families once again, okay? So during all this time, I was telling people what I'm learning, and I was learning about my weaknesses, okay? So instead of being an outsider now at these family gatherings, right? Instead of being the Spider-Man among all the Batmans, now I can be a part of I can feel like I'm within their circles. I can feel like family again. I can feel like friends again. So that's what I did. I changed my approach. For the first time, I had to share my experiences with these people not only in order for me to be successful, but in order for them to understand the things that I'm doing. So I help myself by exercising, okay? It's helping me manage my medication. My time between my off periods have become shorter through exercise. I'm getting better at managing all of my medications. And I want to tell you guys something. Remember those 4.5, 5 weeks I have to raise that $2,000, okay? In that 4.5 weeks, 5 weeks, I raised a total of $5,000 for the Michael J. Fox Foundation, which is great, right? Not only that, I have opened up my story to my friends and families, bringing them back into my circle. I have connected with other people in the Parkinson's community, learning from things that they've learned along the way. I have done more for myself, for the Parkinson's community, in those 4 weeks than I had done in my first 8 years combined. Right? Thank you, yes. And that became my daily thought, right? Remember I said, what can I do to do more today? What can I do to make this better, my situation better? Even if it's just one more step outside or one more rep in the gym, what can I do today that is more than I did yesterday? Now, since 2012, when I started and I finished that marathon, these one mores or these more things that I can do have added to some pretty amazing accomplishments. Now, I continue to push my limits until I think I have become unstoppable, okay? And between 2012 and 2015, I was unstoppable when I ran over 5,500 miles. And I also took part in a 50-mile challenge, along with other people living with Parkinson's. In 2016, I was unstoppable when I continued to run, but then I also became the first person with Parkinson's on record to complete a 100-mile bike ride in under 5 hours. Now that's holding a 20-mile-per-hour average for 5 hours on that bike. In 2017, I was unstoppable. As you guys saw, in 2017 was the first year I was chosen to compete on American Ninja Warrior. In 2018, yes, this is going to go on for a little while. In 2018, I was unstoppable when I returned not only to American Ninja Warrior, but I also finished 4th in my group at the Spartan World Championships. Now, if you guys don't know what a Spartan World Championships, imagine mixing a marathon with obstacles and mud, up and down mountains. And that was in Tahoe. In 2019, I was unstoppable when American Ninja Warrior called me again for the 3rd time, and I completed the Chicago Marathon that year while doing 351 burpees along the way. I'm going to talk about that a little bit later, but for those of you who don't know what a burpee is, you're in for a treat. We'll talk about that too. Now, in 2020, even with the start of COVID, I am unstoppable, okay? Competing in the 4th year in the American Ninja Warrior, I also broke 2 world records, as mentioned earlier, for a number of chest-to-ground burpees in 1 minute and number of plyometric side push-ups in 1 minute, okay? Today, I am still unstoppable. I competed in my 5th and final season American Ninja Warrior. As you guys saw, after years and years of trying, I finally hit that buzzer at the top of that warped wall, which is a huge accomplishment for me. And despite living with Parkinson's, hopefully I wanted to show people that these are skills that are still attainable if you go after them. Now, all in all, I'm going to summarize everything I just said in the last 5 minutes. All in all, these one mores have added up to 5 times on American Ninja Warrior, 1 burpee world record, 1 push-up world record, 16 marathons, 1 ultra marathon, 105 half marathons, and countless 5Ks, 10Ks, triathlons, etc. Now, all of these physical accomplishments are great, right? But none of those compares to the fact that since 2012, my wife and I have raised more than $700,000 for Parkinson's research. Yes. Now, that is a far cry from the 240-pound cane-wielding Jimmy of 2010, okay? Now, I couldn't have done all this if it weren't for the things that I learned along the way, right? Certainly wasn't easy, because Parkinson's and life in general has a way of throwing obstacles in your way, right? And sometimes they seem flat out impossible. But I want to say there's always a way around. You guys remember these things? Right? With this crowd, we all know what this is. My kids call this the Google of the 1900s. Now, it's thick. This one is particular. It's 975 pages, right? Now, if I told you that this was an obstacle that is placed between you and whatever your goal might be, and the only way through it is to rip this book in half and get through it, you would say that that's probably impossible. And no, I am not going to try to rip this book in half. What I will say is that remember those one mores that I talked about, right? Today, we can start with just a page, just the cover. But now, with these one mores, tomorrow, maybe we can go to 3 pages, okay? Now, what I've learned along my fitness journey as I go through these one mores is that in 2015, I ran my fastest marathon ever, 3 hours and 40 minutes. And that same year, I also talked to the person that won that race at a charity event at the end of the day. Now, he came up to me and he says, "Hey, congratulations on your finish. It's really impressive. What was your time?" he asked me, right? I'm like, wait, why are you asking what my time was? Because this person just ran that marathon in 2 hours and 12 minutes, okay? And he's fast, right? And I said, so I felt a little silly. I said, oh, you know, I did it in about twice your time. I did it in 3 hours and 50 minutes. And he goes, 3 hours and 50 minutes. He goes, that's impressive. I'm like, yeah, right? Who are you kidding? You just ran it in half my time. So he was genuine in his response. And I wonder why. So I'm like, well, why are you impressed with a guy that runs a marathon in 3 hours and 40 minutes? And he said, well, yes, I did the same distance in 2 hours and change, but that's just my threshold. That is the way my body works, right? But if you ask me to go out there and run for the same amount of time that you did, for the 3 hours and 50 minutes, I couldn't do it. So by that comparison, you are more fit than I am, right? So that taught me something that day immediately, is that, number one, we are all different, that we are not going to compare ourselves to anybody else but ourselves, right? You are not going to be an American Ninja Warrior contestant, right? But you can be your own version of whatever that might be to you. Now, as you can see, at the end of the day, what I've learned is that by taking your time, going through this one step at a time, a little bit more each day, it is possible for you to get through an obstacle. It just might take a little bit more time, right? So it is possible for you to get through to the other side. You don't have to be like the 2-hour marathoner and do it faster. As long as you get to that finish, get to your goal, and that's great. But think about this while you're training for your ones mores. Maybe your threshold is 50 pages. Maybe your threshold is 100 pages, okay? Maybe your threshold is 75 pages. But you're never going to know until you go as far and as deep as you can. And maybe one day, this is a new book, by the way, maybe one day, 975 pages is possible in one go. Thank you. Now, my new mantra is that nothing is impossible, okay? As long as I believe that something can be done, the only way and the only person who has control over how much effort I put into that, not whether or not it can be done, but how much effort I put into that to find out if it can be done, is me, okay? So then instead of thinking impossible, I look for ways to think, how am I going to make this possible, to make it so that I am possible, okay? Now, remember my symptoms, right? Let's go back to my symptoms. Remember that everyone is carrying their own version. So what did I learn throughout all these years, right? Let's go back to dyskinesia. Exercise has helped me better manage my meds so that I am not overdosing and my medication. I am better timed with all my medication. I have reduced my dyskinesia because of that. Cognitive functions. High-intensity exercise releases all kinds of chemicals in your brains, and that has helped me think sharper, think clearer, and improve my cognitive functions. My posture. When I'm working out in the gym, I'm thinking to myself to make sure that I'm using the proper technique and the proper form so that I can train my body to be in the right posture all the time, including just sitting and standing around. Insomnia. Well, let's be honest, when you're in the gym 4 or 5 hours a day, or if you're running 20 miles, you're gonna be tired and get some sleep. Rigidity. Rigidity, by training my muscles to move and find the balance on all sides of the muscles, not just one, right? So my biceps gets trained, I wanna make sure I train my triceps. I am improving control over my body, and I'm able to move my muscles more efficiently, thus improving rigidity. Constipation. Guys, I'm gonna sit here and talk about exercise all day long, but if you don't change the way you eat to match your goals and your exercise, then you're doing yourself a disservice. But changing the way that I eat has also helped with my constipation. Tremor, guys. Resting tremor is what most of us deal with. By muscle activation, we are actually helping ourselves reduce the amount of tremor, as long as you keep those muscles activated. We've got dystonia. Remember I talk about working those counter muscles? When you get into that state of cramp, for myself it's a lot in my chest and my shoulders and my neck. Once everything is cramped up, I make sure that I've trained everything along my backside and in my core so that I can pull myself out of that cramp sooner than later. We got slowness of movement, bradykinesia, okay? But when I train in the gym, I am making sure that I am following my entire range of motion, okay? I'm not cutting my punches short in a rock-steady gym. I am not lifting halfway and reducing. I'm making sure that I complete the rep before I switch to the other side. And by doing so, I'm training my body to move in this full range of motion, and that has actually helped me with my slowness of movement. And loss of balance, guys, I do a lot of work in the gym that is contralateral, or one side of the body at a time. This helps me identify which side is stronger, helps me with stability, and it helps me improve my balance. Now, remember, everybody is carrying their own version of the burden, right? Not everybody understands. Let's make sure that I don't rip my backpack. I'm gonna put this back on. Second. Now, if you carry all of this burden around, everybody has their own version of this, and if everybody's carrying this around, now just imagine, forget carrying this around for the next 5-10 minutes or so, okay? If you're walking around with this much burden, and you're carrying this much on your back, you can forget about preparing dinner for the family, because all you're thinking about is carrying the burden. You can forget about the report finished being done at work, because that report is secondary to what you're really thinking about, which is carrying all this burden. So I like to flip it around and think the other way. What if, instead of thinking what all this burden is preventing me from doing, playing with my kids, getting dinner done for the family, instead I start working with these burdens, okay? I can still do X, Y, and Z despite having these, and then I can expand on that. I can still accomplish things, like if I need to go to the gym, I'm carrying 100 extra pounds. Jimmy, get down and give me 5 push-ups. All right, fine, 5 push-ups, no problem. You want some clapping push-ups? We can do that as well. All right? Thank you. So what I'm trying to say is that if you stop looking at your limitations and start looking at what you can still do and expand on that, you can still achieve things that you didn't think was possible. Now, at the same time, guys, as strong as I've gotten, I have to know my limits. I know that if I try to stand up right now, orthostatic hypertension may come into play, and I may end up flopping right down here instead of finishing my talk for you guys. So I'm just going to take a second before I stand up. Take a deep breath. Always know your limitations. Be safe out there, especially when you're exercising. We're good. Thank you. I have to be honest, though. The stronger that I got, my symptoms didn't necessarily go away, right? But what I did is I prepared my body to better handle all of these symptoms. I made my body stronger. I made my body subconsciously or through muscle memory realize, hey, I've been in this situation before, but I was in the gym, but now in real life, if I'm taking a fall, right, now my body knows how to react just from muscle memory, okay? In order for me to stay ahead of this disease, guys, I need to do what some might consider this to be a crazy amount of fitness, right? But I found something that works for me, and I encourage you guys to go find something that works for you and your everyday life living with the disease. That means that in order for me to do that, I have to find motivation, right, to get up and move, because it's hard, okay? But that's not enough. It's hard to keep fighting motivation. Every day, it's hard to find reasons to get up and move. Especially during those COVID years, we were all stuck at home, right? We didn't have access to our doctors. We didn't have access to our gyms. We didn't have equipment to use at home. We all have to sit here and find different ways of doing it, and motivation was hard. That's why you gotta be more than motivated, okay? You also have to be disciplined. You gotta be able to say, I know I'm supposed to be working out right now. This is where I work out every day. I'm gonna go downstairs even though I don't, or downstairs or outside or whatever. I'm gonna get my running in. I'm gonna get my jumping jacks in. I'm gonna get my squats in. I'm gonna get my sit and stands in, right? Let's get these things in. You gotta be disciplined, even though you don't feel like you wanna do them, okay? Sometimes even motivation and discipline isn't enough, because when there is absolutely no outside force motivating me to move, okay? When I'm just dead tired to move around, and I've told myself already that quitting is the best option, I have to rely on determination. I'm determined to stay ahead of PD. I'm determined to give my body the best chance I can to combat Parkinson's. I'm determined to never go down without a fight. See, since 2012, guys, I have used motivation, discipline, and determination to help me stay committed to the fight, okay? It's allowed me not only to prepare my body, but it has also given me a platform to tell my story. Now, why is that important? Remember that Runner's World magazine I pulled up in the back of my back pocket on the airplane? Well, in 2015, Runner's World published a story about me running a marathon living with Parkinson's. And then again in October, remember I talked about that Chicago Marathon with the 351 burpees? Okay? Runner's World published another story. Hopefully, someone else will read my story, and that will inspire them to move, and it will inspire them to tell their story, and it will, in fact, inspire other people to move. Now, just remember that we all have our versions of our stories to tell, right? No matter how big or small your story might be, or how big or small you might think it is. It's a big deal to somebody. Somebody's going to listen to your story, and someone's going to get motivated. And you may never know who that person is, but it's why it's important to keep telling your story, because you never know who you're going to inspire and motivate. I always say, little Timmy and little Peggy down the street picking their nose, I tell them my story because they might grow up and they might find the key that ultimately leads to a cure for all of us, right? Now, I can't stop doing what I'm doing because, once again, guys, Parkinson's doesn't stop. Medication, exercise helps, but unfortunately, Parkinson's doesn't go away. So I might be able to compete in nationally televised competition like American Ninja Warrior and run for miles and miles, but I still have issues tying my shoes, buttoning my shirt, okay? But those are things that I have difficulty with. But things like running a marathon, or things like, forget running a marathon, things like just going to the gym and doing 50 jumping jacks. It's something that anybody can obtain if you put your time and effort into it, right? So I'm still hearing things like, Jimmy, you don't look like a person with Parkinson's. Can you imagine how much stronger or faster you might be, if you didn't? Well, when I was diagnosed, I was falling a lot, right? And I was still falling a lot, even though I was running all these marathons. And I want to tell you guys a story, because it was during COVID that gyms were closed, and I figured, what can I do to continue moving and continue challenging myself? And then I realized that, you know what? I'm falling a lot, so what is an exercise from a physical activity point of view? What is a physical activity that I can do to help me in case I take a fall? And guys, that is a burpee, okay? Show me a hand, or how many of you know what a burpee is? Oh, good. For those of you who don't, it's a treat. So, for those of you who don't know what a burpee is, this is actually a controlled fall and getting yourself back up. So it's getting yourself down to the ground, jumping up, and getting up. That is a burpee, okay? So I started using that as a way to train myself in case I do fall. My body is trained to embrace that fall, to take the hit, and I'm also building strength so that I can get back up. I started doing those 5 at a time at the end of my workouts, 10 at a time, 20. And then I realized, hey, I'm getting pretty good at this. So during COVID, I was doing a lot of burpees, okay? So it is that desire, okay, to be better than normal that has driven me to always train for a purpose. And my purpose for those burpees was so that I can be safe during a fall. I noticed I got faster, I got stronger. And then I was like, just one day, I was like, I wonder what the world record is for number of burpees in a minute. And I looked it up. I'm like, 28 chest-to-ground burpees in 1 minute. I can beat that. So I started training for that, okay? And I wanted to show you guys that this is that world record attempt. The chest-to-ground burpees, chest to the ground, arms have to extend past the side. You'll see some orange tapes. My feet have to come back to that orange tape, or else they don't count that rep. Okay? At this time, I was contemplating my life choices. Why the hell am I doing this? This keeps going, and she sees judges, timers there, and we had to send Guinness World Records multiple camera angles so they can see everything. And at the end of the day, guys, I was able to do I actually did 31 of those in this attempt, and I broke that world record, even during COVID. Thank you. I get tired every time I watch it. It's still going. I think that was it. I think I'm done there. So we all want to maintain what our version of our normal is, right? But the path that we all take can be a little different. All right, what might be a path that's right for you may not be right for me. All the things that I do in the gym, as I mentioned, has a purpose with my everyday life living with the disease. It is designed to teach me something. Walking around obstacles, okay? Remember when Dr. Zayas talked about the little dog, right? Walking around or kicking the dog down. I'm kidding, don't kick your dog. But these are obstacles that can happen without you realizing it and can be a surprise. But if you train in the gym, like how you want to live, these are things that you can help improve in your everyday life, okay? So we must know what our strengths and weaknesses are, and this is also another reason why I train in the gym, because then we can make choices that can define our path. 20 years ago, I decided to ignore my progression. 10 years ago, I decided to be a better father and a husband and to be a better patient for myself. 8 years ago, I chose to become a voice for the Parkinson's community, okay? 5 years ago, I chose to better understand the way my body moved under stressful conditions, right? American Ninja Warrior is pretty darn stressful. But I did all that so that I can turn my weaknesses into my strengths. Even today, right, I take those opportunities that are hidden within my everyday life, even though they're hard, to go do to take those opportunities to achieve new heights. Now, this is my chest-to-ground burpees world record certificate, but if you guys remember when I was doing push-ups and the burpees, I got really good at doing push-ups. So I looked up most push-ups in 1 minute for a world record, and this is what I found. It is a lateral plyometric push-up. Both hands and feet have to pass that orange line. There cannot be any bend in the knees, cannot be any bend in the hips. Once again, we had to send multiple camera angles to Guinness for them to count. And you can see Tori, who is my coach, being my eyes and ears back there. And you'll see her when she raises her hand, she actually called out a couple of my attempts that didn't count, right? I don't know, whose side was she on? I don't know. But once again, at this point, I was contemplating once again my life choices. But I'm going to spare you the rest of this, and I'll just keep going, moving forward. But, you know, this year, after achieving these world records, I'm choosing to make the choices that I'm making this year is I'm choosing to retire as an American Ninja Warrior. Not because I can't do it anymore, and not because Parkinson's is my main reason for doing so, but I understand that I need to preserve my body for the long run. I've got many years left to live with this disease, okay? And all these things, forget Parkinson's, people who are healthy, who are in their 20s and in their teenage years, who are doing American Ninja Warrior are putting a lot of stress on their joints and muscles. So I need to make sure that I can live the long run. Now, it doesn't mean that I stop exercise, right? I'm just gonna find different ways of doing it. And in fact, I'm going to also spend more time teaching others the lessons that I've learned that have helped me. So this gentleman here is learning how to balance on a balance beam while carrying a PVC pipe that is holding a 20-pound weight on just one side only. Initially, when you start, it's gonna be easy, but as you start moving along, trying to keep your balance, that weight is going to start to sway. Every time the weight sways, it's gonna pull your body in one direction over the other, and you cannot predict where it's going to go. So I like to do these exercises with people in Parkinson's. This gentleman, his name is Bill Buckley, by the way. He walked across America on world record pace, living with Parkinson's. He works out with me in the gym, and we are working on some balance work, okay? But before I wrap up, guys, I'm gonna leave you with this. Just remember that on any given day, you guys all have opportunities to make choices. What you choose to do can make a difference. Big or small, doesn't matter, right? Do I sit or do I get up? Do I eat that cookie that's sitting back there, or that slice of cake that's sitting back there, or find a piece of fruit, right? Go for the cake, it tastes better. But do I have one more rep, or do I have one more step today in the gym and in me when I'm outside moving about? Okay? No matter what choices you make, it is completely up to you. For me, I choose to find new challenges despite living with Parkinson's. Okay, so in closing, guys, this was a hotel gym, by the way. Just finding new challenges to challenge myself. But in closing, guys, I leave you with this. There is a movement with people with Parkinson's. And I want all of you to join that movement, and all you have to do is move. Thank you guys very much for your time. Thank you. Thank you, thank you, thank you. Keep fighting, everybody. We have time for questions? Yeah? And I think it's questions for everybody, right? Here, I'll let you. And if you guys are, anybody looking for a phone book recyclist, that's my new job.
I'm very sorry I have to talk after that. That was pretty incredible. Thank you so much.
I'm just going to leave this here.
Okay, I'm not taking it. We're going to answer some questions. We haven't gotten too many, so I think I'll just take the microphone down there. But you can ask us some more questions if you want to come up to one of us. That's also fine. Before I do that, I have a couple of housekeeping things, and I can see Susan White out of the corner of my eye, so I'm sure she's coming to tell me.
Thank you.
Please leave the post-tests and the evaluation forms filled out on your table before you go. Again, we really use those to kind of make our programs better every year. The other thing is that all of these talks will be available on the virtual platform for the next month. So you just use your email that you used to sign in are used when you signed up for the presentation to actually get on the virtual platform. So with that, I think we have about 3 questions, and then we can take them from the audience, or you can come up to us individually.
So my question is, I should stand. Okay. The supplement carnosine, is it helpful for neurological issues such as Parkinson's disease? So carnosine is a supplement similar to CoQ10. It has antioxidant effects, so it goes into your brain and potentially protects your cells from destruction, especially ones that produce dopamine. But similar to a lot of the supplements, these studies are currently in animal models. We need to take it one step further into human trials. So for carnosine, a lot of them are still animal trials. So like CoQ10, we need to see more in human trials to know if it works for us or not. But so far in the animal trials, it's promising. So we'll see what the future shows.
So I have a question here. If levodopa was abruptly stopped, can we resume? And the answer is yes. Never stop the levodopa abruptly. Otherwise, you will have a lot of problems, and technically, you have a 4%, up to 4% of death. So you have to be careful. How to restart the medication? Well, maybe you can start 50% of what you were taking, and then progressively. This is not a question that we have a specific answer. Everything depends of the problem, but never stop the levodopa abruptly. There is no reason to do that. And if you're in the hospital and they stop the medication, try to contact your doctor, your Parkinson doctor, as soon as possible.
There's a question for me on a particular compound that is being studied. It's a phase 2 study of a compound that is attempting to determine if this medication decreases the progression of Parkinson's. So not just as a general remark about studies that are available, I encourage everyone to go to one of 2 websites, maybe both of the websites. One is the Fox Finder. Fox Finder is from the Michael J. Fox Foundation, and they have all of the trials that are actively enrolling are actually listed there. Fox Trial Finder, and so you can find out which trials, and when you put in your location, and it'll tell you where the enrolling sites are, because not every single study is available in every single center. So I think that's an incredibly valuable resource. The other place you can go is clinicaltrials.gov. That's a little bit more for scientists and researchers, not as much as friendly for patients and family members to visit. So go to the Fox Foundation, and you can see, and the compound that I was asked for is actually recruiting right now. And so, depending on where you might want to travel, you can look that up and see if you can participate. Thank you.
I had a question. At night, I get very short-tempered with my brother. He'll come over and I would go, "Now, what do you want?" Is there any way to deal with that so I don't get so argumentative or upset when I get disturbed in the evening? Also, do you know if anything is going on with the trials or studying of nicotine on the Parkinson brain?
I guess I'll answer the second question first. They did a pretty large study with nicotine probably 5-6 years ago, I think. Unfortunately, that was not positive. I don't know of anything currently. I don't know if any of you guys know. That was a couple more. But that was a pretty large study. Unfortunately, it was not positive. As far as the second one, maybe I can talk to you separately. But, I mean, it really depends on the other things that are going on. I mean, I don't know if depression is playing a role.
I do suffer from severe depression and anxiety, and I'm taking medication for that fluoxetine.
Yeah, so I think the answer would probably be to talk to your treating doctor, and maybe y'all can come up with a game plan to better treat that. Yeah.
Yeah. Really,
Hi, I just wanted to add something and make sure everybody can hear me. As far as your brother is concerned, so I recently had a situation like this with my daughter. My daughter's a teenager now, and of course teenagers hate everybody, right? But I talk, this is something that is not medicine related or anything like that, but I think this is something that's very important that we can all do with our close friends and family, is I actually told her, I said, look, if I ever snap at you, okay, know that I don't mean it, right? But having that conversation opens that up so that, there's less, tension between you and the other party, in this case, me and my daughter, you and your brother, right? Say, look, when you're feeling this, is look, I know I snap at you. I know, own up to it. I know I do it. I'm sorry, but just know that that's the Parkinson's talking. It's not me. I love you, and that can keep the doors open. My daughter actually has started opening up more to me after I told her that. So, just something to think about.
Think positive. That if you think positive, and don't think it's possibly Parkinson's related, then it won't be Parkinson's related. Does that do anything to help?
I think having a positive mindset and some of the things that Jim had mentioned, yes, is very important.
Because someone comes up and I go, that could be Parkinson's. It could be just getting old. I don't know. See, I suffer from OLD.
I hope
I just turned 61 this year.
I hope that was helpful. I've got.
Thank you.
You're very welcome.
I'll go with you and schedule an appointment this month.
Thank you.
Thank you.
I got a question about non-invasive ultrasound and will it replace DBS? Those are surgical therapies for Parkinson's disease. I would say no. There are pros and cons to both approaches. From my standpoint, the non-invasive ultrasound, although it's now approved for Parkinson's, seems to be the most beneficial for tremor. DBS tends to help more of what we call the motor symptoms, and I think we've talked about that quite a bit in our lectures than I've seen with ultrasound. There are pros and cons to both, with that being said. So I would say a pro with ultrasound is it's not nearly as invasive as DBS. Cons, to my standpoint, for the most part, they're just doing one side. So if you had a really significant tremor on one side, that might be a good option for you. The other con that I would say with ultrasound compared to DBS is that what I always tell folks, if they're thinking about surgical therapies, if that's a discussion we're having in a clinic visit, DBS is very modifiable over time. So we use electricity, again, to modify your symptoms, and we can adjust that electricity, how it's delivered. There's a lot of variables that we can play with. That's not the case with ultrasound. Once you get the procedure, and sometimes it can take a little while to get the full effect, but once you get that effect, you can't change it unless we did another procedure. I think that's it. You guys are welcome. We can just talk about it. Thank you guys so much. Thank you guys for coming out. Thank you to all our speakers, Dr. Akbar and Jimmy. It was just wonderful having you all here. So thank you.